Hello everyone. So let us start the session today. So I'm very happy to announce that PW Meded has come with this new series, that is the PYQ test and discussions for especially for the NEET PG, the upcoming NEET PG 2024. So for orthopedics, I have come prepared with every question which was asked in the past. At least I have covered to maybe some 10 to 15 years. So let us now quickly learn what we are going to read today. So before that, I just want to tell you all that so today's discussion will be based upon only your PYQ and PYTs, right? So it will not be like a question and answer pattern, but what I've come is with the various images which are mainly given in the exam. So usually orthopedics is image based. Most of the questions are image based. So today I've come with various images and we're going to quickly form question and we're going to answer. So so topics, like I told you, it is the PYQ and the PYT exclusively from the orthopedics. So I'm going to cover every question. So if you follow this 1 hour class, you'll be thorough with every question which was asked in the past. Fine. So that much I can assure you. And now what I want to tell you just before the start of the session is whatever tiny steps you're taking will count and will show you the result at the end. For now you may not see the change, or for now you may not feel the result, but end will be really beautiful if you continue your persistence, if you continue to aspire, and if you continue to put your efforts. So don't get disheartened that usually the middle path will be usually messy. It will be very difficult in the beginning, middle and messy, but always beautiful at the end. So you have to wait for that. And then now what is the other thing is, you have to remember that whatever happens, you have to continue your efforts. And how do you put your efforts? You should act really smart where every mark counts. So because you have to remember that NEET PG is a competitive exam, so every mark counts. Even with one tiny mark you can go back 1,100 ranks behind somebody else. So act smart. So smart acting is nothing but you're going to read the PYQs and PYTs and you're going to revise it as much as you can. So coming to orthopedics, the first important topic is here the tumors. So usually questions are asked from tumors. Every exam has at least one question from the tumors. So quickly let us revise what are the important questions from the tumors. So here I want you to be quick and recollect, just nothing to write, just keep recollecting all your answers, whatever you know regarding that topic, so that this will be useful as an active recall for your exam. So the first one, as everybody know, this is nothing but your, yes, very good, these are benign tumor as I've already mentioned here. So the name of this is osteochondroma. So this is osteochondroma. So as the name suggests, there is a bone element in it, and then when I say chondroma, that means there is also a cartilage involvement in this, right? So what is that bone and cartilage? So this is also called as exostosis. What do you mean by exostosis? That means there is a bone growth. So there is a overgrowth of the bone, and usually they tell that this is not a tumor, but this is usually a disturbance which is created in the growth plate. So this is called the aberration of the growth plate. And if you see, as the growth is opposite to the joint, if you remember, this is growth which is opposite to the joint, because the growth plate is placed in such a way where the growth bone occurs towards the upper part of the femur, right? So this is called the exostosis or the osteochondroma. And what you have to remember is, this is a bone, as I've told you, this is the bone, and it is covered with this cartilaginous cap. So that you have to remember. So this is covered by the cartilaginous cap. And why are we so why are we so involved to know that what is cartilaginous cap? Because this is the area where it might turn to malignant. So what is that malignancy? It is chondrosarcoma. So this is chondrosarcoma, right? So you have to always order, or you have to investigate. What is the investigation of choice? The investigation of choice is your MRI. So you have to see the cap, the thickness of the cap. If the cap thickness is more than 2 centimeters, so you can tell that there are some malignant changes which can occur in that, right? So usually what is the treatment for it? We go for excision. So remember, exostosis is for excision. The treatment is excision. And what is the first main important purpose they go for excision? So mainly the important purpose is cosmetic purpose, but there are other other region, such as if it encroaches on the nerve or any bursa or any vessel, so you have to remove it. So that is it. You have to remember the bone, that is the bone, and then there is cartilage. There is a bone and then there is a cartilaginous cap over it, right? This is usually not seen on the X-ray. For that you have to go for the MRI. So that is it. You have to just, this is an IBQ, you have to remember this IBQ, right? This is osteochondroma. But one more important question I want to ask you is, what is that name which is given to multiple exostosis or multiple osteochondromatous, multiple lesion? Yes, this is called as diaphyseal achalasia. This is called as diaphyseal achalasia is the term given to it. So whenever there are multiple osteochondromas, if you see in a particular body, that is called as diaphyseal achalasia, right? So these are all the points regarding to your osteochondroma, right? And then coming to this, your osteoid osteoma. So what is this? So if you see, you can see there is a periosteal reaction, but there is nothing which can be seen. So there is no lytic lesion or nothing in the exact part of the bone, right? So what happens is there is a small nidus which is present in the center and which is covered by sclerosis. So usually this nidus, what is there, is less than 1 centimeter, which is not seen on the X-ray, but what you can see on the X-ray is this sclerosis. So this is nothing but your osteoid osteoma. As the name suggests, what is osteoid? That is bone formation. So bone is forming around the nidus. So this is called osteoid osteoma. Now, how do you identify this nidus? Because I told you that this is not seen on the X-ray, which is less than 1 centimeter. So what is the investigation of choice? So the investigation of choice here, it becomes the CT scan, because what are you identifying? The lysis surrounded by sclerosis. So whenever you want to see something which is sclerotic, something related to cortex, you go for CT scan. So what you have to remember here, whenever you want to see something related to cortex or calcification, you go for CT scan. Similarly, something you want to see in the marrow. So what is the choice of investigation? Then the choice of investigations becomes MRI. So remember, C for C, M for M. So whenever you want to see something like related to marrow, for example, Ewing sarcoma, then you go for MRI. Anything, usually we go for MRI. All the tumors, usually we go for MRI. Then whenever which is related to cortex or calcifications, you go for CT scan, right? But remember the cartilage is, again you have to go for MRI. Like whatever the changes in the meniscus, again you have to go for MRI. That is only the one exception which you have to remember. So now for osteoid osteoma, what are the important things which you have to remember? So first you're going to see the nidus, which is covered by sclerosis, which is usually seen as a periosteal reaction on the X-ray. And what is the investigation of choice? The investigation of choice is your CT scan. And what is the buzzword, the peculiarity which the question is asked? The question is mainly asked that is related to night pains. This you have to remember regarding your osteoid osteoma, that patient will have night pains because there is a release of prostaglandins. What is the name of it? The PGE2 prostaglandin, and it is relieved by aspirin or NSAID. Right? So this is the peculiar question. They frame that patient presents you with the night pains, which is relieved by aspirin or NSAID. And then what is the diagnosis? So this is also a therapeutic test which is given for osteoid osteoma. Okay, fine. So that is about your osteoid osteoma. Now coming to this particular image. So this, I think you all can answer. So this is nothing but there is some change, right? There is some change which you can see. And one more thing, the osteoid osteoma, what you have to remember is this is seen in diaphysis. So this is seen in diaphysis, right? So this is seen in diaphysis. And osteochondroma, if you remember, this is seen in metaphysis. So osteochondroma is metaphysis. So this is the area where the growth plate is present, like the metaphysis. And osteoid osteoma in diaphysis, right? So now the third one, this is very, very important. He asked like 2 years back, and this is a repeat question again. So this is nothing but your, yes, this is nothing but your fibrous dysplasia. So where you can see that usually the diaphysis is involved, and sometimes it can be seen even in the metaphysis. So these are the two important things. But what is fibrous dysplasia? This is nothing but the bone, whatever is there, it is converted, like it is converted into fibrous tissue. Hence, what is the appearance you see here? You see the ground glass appearance. So, ground glass appearance is seen in which condition? It is seen in your fibrous dysplasia. But what are the important things which you have to remember? Yes, this fibrous dysplasia is of two types. It can be monostotic or it can be polyostotic. What is mono? That is single lesion. What is poly? So, multiple fibrous dysplasia lesions are seen. So, that is your polyostotic. So, then there is one more syndrome which you have to remember. Yes, so when you see this with the kephaloid spots, right, these are the hyperpigmentation spots, and when you see the precocious puberty with kephaloid spots, precocious puberty is called which syndrome? Yes, this is called the McCune-Albright syndrome. So, this is your McCune-Albright syndrome, right? So this is very, very important, asked previously. So everything is asked previously, but this is very recently asked. So I'll just put Q so that you will revise it once again. So this is about your fibrous dysplasia, where you see there is a ground glass appearance, usually seen in diaphysis, but even you can see it in metaphysis. Ground glass appearance, it could be two types, the monostotic or the polyostotic. And whenever you see associated with kephaloid spots and precocious puberty, this is nothing but your McCune-Albright syndrome. So this is your fibrous dysplasia. And very important, what is the deformity? The Shepherd-Crook deformity. The deformity is your Shepherd-Crook deformity, right? So every word, every bit is an MCQ. Whatever I have written here, every word is an MCQ, right? So this is a Shepherd-Crook deformity which you see in fibrous dysplasia. Fine. So now moving on to the next one. So these are all the various cystic lesions which are put together. So you can see the first one is a cyst, second one, third one, and the fourth one. But let us understand what is the difference between the each. So first one, if you see, this is a cyst which is again present in which region? It is present in the metaphyseal region. So this is a cyst which is present in the metaphysis. Can you see anything abnormality in it? So there is nothing, but it is a homogeneous appearance, right? You can see everything is so clear, homogeneous, and there is no periosteal reaction, right? Hence, you can conclude this as a SBC, that is a simple bone cyst, or a UBC, which is called as a unicameral bone cyst. But what you have to remember in point of exam, so in exam, whenever this cyst present with a fracture, this is called as pathological fracture, and that sign is called as fallen leaf sign or the trap door sign. This much if you remember, that is enough for your exam. So fallen leaf sign or the trap door sign, this is very, very important, but that is associated with any fracture. If you see a fracture, so you will see that some small bony part has fallen into the cyst, but this should be associated with the fracture here. So whenever you see a fracture with a cyst and a small particle of the bone seen in the cyst, it appears as a fallen leaf sign or a trap door sign, right? So that is nothing but your simple bone cyst. So this is your simple bone cyst. Now what can you see here? So you can see same again, but this is something, this is also seen in the, yes, metaphyseal region. So this is also seen in the metaphysis, yeah. Yes, this is also cystic, seen in metaphysis. But what you can see that this, so what is the difference between these two? If you see this one, so it is inside the borders, like it is inside the borders, whatever you can see. But if you see, this has been expanded. So this is nothing but an expansile lesion. So this is an expansile lesion. It is seen in the metaphysis. And so what is the main differential diagnosis here? So this could be a giant cell tumor. But what you do, you take an MRI. And if you see in the MRI, there are multiple fluid levels like this, then this is nothing but your, yes, aneurysmal bone cyst. This is your A, B, and C. That is your aneurysmal bone cyst, right? So this is the aneurysmal bone cyst. So usually what we do, you see an expansile lesion which is seen again in the metaphysis, right? You see an expansile lesion in the metaphyseal region, and this is also eccentric. So there you should also remember that this is also eccentric and expansile, right? But in GCT, what you see, there are some trabeculations. In GCT, you see there are some trabeculations. So this is your giant cell tumor, where again you see everything which is associated with the aneurysmal bone cyst. Like you see, this is also expansile, this is also eccentric, this you see some trabeculations more in case of your giant cell, hence this is called as your soap bubble appearance. This is called as a soap bubble appearance. And what is the most important feature of this? Yes, very good. This is seen in the epiphyseal region. This is seen in your epiphyseal region. So there are two important lesions which you have to remember which come out from the epiphysis. So one is GCT, the other one is your chondroblastoma. So GCT and chondroblastoma. That was what we first read, was it was osteochondroma. Now this is your chondroblastoma. But what is the most peculiar thing of GCT? So GCT is seen only after your skeletal maturity. So that is the one thing which you have to remember. So this is always seen after your physis is closed. So after your skeletal maturity, you see a soap bubble appearance which is eccentric, which is expansile, which is in the epiphysis, and on palpation you see there is an eggshell crackling sound. Usually we don't feel that, but usually it is written in the books that there is eggshell crackling sound which is present in case of GCT. So all the E's together we confirm the diagnosis to be as GCT. So don't get confused between aneurysmal bone cyst and GCT. At your level, just remember, whenever you see this cystic type of lesion which is expansile in case of metaphysis, it is ABC, and in case of your epiphysis, it is GCT. Fine. So that is the thing which you have to remember about the cyst. And let us now conclude the cystic lesions with the small cyst which is seen in the hand. So this cyst is seen in the hand, and this is also again seen in the metaphysis region, right? And this cyst is something in the cartilaginous group. So this is nothing but your enchondroma. Enchondroma. So you see this cystic lesion which is well defined in the metaphysis and usually has predilection to the hands and the feet bones is your enchondroma. But again difficulty arises where you have to remember that there are two syndromes which are associated with this. One is called the Ollier syndrome, where you see multiple enchondromas. This is multiple enchondromatosis is Ollier's syndrome. And then you have Maffucci syndrome, where you see hemangiomas together. So whenever you see enchondroma plus hemangiomas and some plebolith on the x-rays, so this all put together is called your Maffucci syndrome. So what is enchondromatosis? It is the Ollier's syndrome, right? Multiple enchondromatosis is Ollier. So we have learned 4 different syndromes. The first one is Ollier's multiple enchondromatosis. The second one is Maffucci's, where you have associated enchondromatosis with hemangiomas, and the third one is your McCune-Albright syndrome, where you have multiple polyostotic fibrous dysplasia with capillate spots and your precocious puberty. And the fourth one is diaphyseal achalasia, where you see multiple osteochondromas. Fine. So that completes the benign tumors. Now let's move on to important malignant tumors. So the very important malignant tumor which you have to remember, which is usually seen in the diaphyseal region. So diaphysis is the clue for you. And what is the one more clue? It is seen in the first decade. It is seen in the first decade. It is seen in the diaphysis. And what is the one more important clue is this resembles this whatever the disease I'm going to tell you, this resembles more of an infection. Why am I telling this? So in this you can see there is a raised ESR, and you can see patient with fever, then you can see patient presenting with anemia. So all this will put you into assuming that this condition is your infections. But what you have to remember is, you have to always remember that there is an important condition called Ewing's sarcoma. So this is the Ewing's sarcoma, where you see the periosteal reaction in case of your as appearing as your onion peel. So periosteal reaction is seen as the onion peel. So this is called laminated appearance. So laminated periosteal reaction, which is nothing but your onion peel appearance on the x-ray. Or sometimes here this is like the hair on end appearance, right? So hair on end appearance or the laminated matlab it will be like this. So So this is your laminated. It is giving resemblance as the onion peel. So this is nothing but Ewing's sarcoma. What is important is this mimics infection, that the patient presents with raised ESR, fever, anemia, and complaining of pain in the thigh. So usually we think this is something related to infection, and then we treat accordingly. But usually the patient does not respond. So why you have to be careful is, so this is a chemosensitive and a radiosensitive tumor. So these are the very important 2 points which you have to remember, that it is chemosensitive and radiosensitive. But usually the radiation is not used for the treatment. We usually give chemotherapy. So we usually give chemotherapy, but we don't give radiation to this tumor. And there are certain important immunochemistry, like the histochemical markers, where you remember the CD99 positive and MYC2 positive. Right, so this is MIC2, that is MYC2 positive, and CD99 positive, and it is CD45 positive, non-specific enolase. You know better than me all your pathology, right? So I'm just writing it for your integration. So sometimes they may ask with the biopsy. And one more important thing on the biopsy, what you see, this shows as the small blue cells, right? So round small blue cells. So everything is round because it is a neuroectodermal tumor. If you remember, this is a neuroectodermal, like your medulloblastoma, a neuroblastoma. So like that, it also belongs to that category. So that is why it is all this positive, that is CD99, MYC2 positive, CD45, like that. So this is Ewing's sarcoma for you. These are the important points which you have to remember, which might ask as a question in the exam. And then what is this? This is very, very important, where you see the periosteal reaction. The periosteal reaction here, the first one is nothing but there is an elevated periosteum. So this is nothing but your Codman's triangle. So Codman's triangle, and the second one, the first one we know that it's Codman triangle because it is an elevated periosteum. The second one is your, yes, this is a sunburst appearance. So this is your sunburst appearance. So this is the two things, the Codman's triangle on your sunburst appearance, are nothing but there are the feature of very important osteosarcoma. This is very important, and this is seen in your second decade, and it is seen in the metaphysis again. So this is seen in the metaphysis. So metaphysis, second decade, whenever you see these two periosteal reactions, that is your Codman's triangle and the sunburst appearance, it is indicative of osteosarcoma. So why again you have to deal with it? Because this is also chemosensitive, where there is chemotherapy advised to it. So we give adjuvant chemotherapy, neoadjuvant chemotherapy, and then we treat it with the surgery. So what is the integrated question which they may ask? So one important thing which I want to add is, this is related to P53 gene mutation. So Lee-Fromney, if you know the Lee-Fromney syndrome, where there is a mutation to P53, so this osteosarcoma is also related to P53, and it is also related to your hereditary retinoblastoma. So whenever you have any patient with the hereditary retinoblastoma, so you can also expect this osteosarcoma to be seen in this particular individual. So these two important things which you have to remember. So that is, one is P53 Lee-Fromney and as hereditary retinoblastomas. And this also you treat with the chemotherapy. You give neoadjuvant chemotherapy, and then you treat the surgery, and then you give again a chemotherapy. So this treatment of this depends upon the lesion. So you take the MRI, you stage it, and then you decide the treatment. The treatment may vary from the reconstruction or up to the amputation. So that is about your osteosarcoma. What you have to remember is the Codman's triangle and the sunburst appearance is seen in your osteosarcoma. The periosteal reaction is seen in your Ewing's sarcoma. Then what are these? These are called what? These are called the punched out lesions. So these are called the punched out lesions, right? It is like the punching machine you have. So exactly that round which is seen, this is the punched out lesion which is seen. And what is that important condition? This is multiple myeloma, right? So multiple myeloma is one condition where you see punched out lesion, and this is one of the most important and most common tumor, that is malignant tumor seen in orthopedics, that is multiple myeloma. So what is the cell which is affected here? The cell which is affected here is the plasma cell. Very good. So the plasma cell is affected, and hence because this plasma cell produces a lot of immunoglobulins. So whenever there is a tumor for it, so these immunoglobulins are getting transferred there to fight with the tumor. Hence these patients are subjected to more infections. And then there are high hypercalcemia. So there are all the symptoms of increased calcium which you see in case of multiple myeloma. You usually get the question integrated with the medicine. So general medicine knowledge is important, like what are the various diagnostic tools which is used, and what are the various immunoglobulins which are present in this particular condition, right? So from orthopedic, they usually put up this x-ray, the skull x-ray, which punched out lesions. The diagnosis is multiple myeloma. Understood? So now that is about important tumors. Then there are certain important tumors which are very specific buzzwords. So they don't ask anything more than that. So I've coined that important words for each specific condition. So whenever they want to ask you about hemangioma is nothing but this is usually an incidental finding. So usually incidental finding, and what is important here is the two appearances of it. So one is this is the, yes, this is your corduroy appearance. And when you take a CT scan axial view, it appears as the polka dot. So like this on the CT scan, it appears like this, something like this on the CT scan. That is the axial view. So this is the sagittal view where you're seeing that this appears like this. So this is called the corduroy or the jail bar appearance. On an axial view, it is seen as the polka dot. So that much if you remember with hemangioma, it's very it is good, right? It is enough. And now coming to chondroblastoma. So we have already dealt that the chondroblastoma is seen in the epiphysis. So one more differential diagnosis for a lytic lesion is your chondroblastoma, right? And then what is important is on the biopsy. Whenever you take a biopsy, you see chicken wire appearance. So chicken wire appearance is seen in case of your chondroblastoma. So this is your chicken wire appearance. So this is the chicken wire what I was talking about. So this is the chicken wire, and the appearance of your cells will be present like a fashion, the chicken wire fashion. So in the GCT, what do you do? What do you see in GCT? What is the biopsy you see? You see various giant cells. So hence it is called the giant cell tumor. So in biopsy, you see various giant cells, and usually the cell of origin is a mononuclear cell, and all these nuclear cells will form together, that is resembling as a giant cell. So you see various giant cell in multiple mononuclear cells. So there are huge mononuclear cells, and in between them you will find the giant cell. So that is the appearance of your giant cell tumor on biopsy. On chondroblastoma, what you see this chicken wire appearance. And similarly, fibrous dysplasia. What you see in fibrous dysplasia? So fibrous dysplasia, you see the Chinese letter pattern. You see the Chinese letter pattern appearance. So these are the three important biopsy appearance in terms of your as long as your orthopedics is confirmed. This is three. So one biopsy appearance is what you have to remember is multiple giant cells you see among the mononuclear cells, and then you see the chicken wire appearance in your chondroblastoma, and then you see Chinese letter pattern in case of your fibrous dysplasia. So that much if you remember, it is enough. Then coming to the adamantinoma. Adamantinoma, what you have to remember is this is one more thing which is usually seen in case of your diaphysis. So this is usually seen in diaphysis, and the buzzword for it is the giant cell, the soap bubble appearance. So you see the soap bubble appearance in diaphysis. So whenever you see a soap bubble appearance in diaphysis, that is nothing but your adamantinoma. So adamantinoma, it is the epithelial cell origin. So origin is epithelial cell, and whenever this adamantinoma is seen in jaw, this is called as ameloblastoma. So that much you have to remember. So adamantinoma, whenever is seen in your mandible, it is called as ameloblastoma, right? And this is the adamantinoma what I was telling about. So if you see, the location is the diaphyseal location. So this is the diaphyseal location, and similarly you can see the soap bubble appearance. So the cystic lesion like the soap bubble appearance, whenever you see in the diaphysis, it is your adamantinoma. So that much if you remember, very good. And then comes the chondrosarcoma. So this chondrosarcoma, what you have to remember is there are two. So this is primary and secondary. So why am I mentioning primary and secondary is primary is one which develops directly as a chondrosarcoma. But what are we interested in is the secondary is one. Why am I interested in secondary? Because whenever you read about this Ollier syndrome, whenever you read about the osteochondroma, and whenever you read about your Maffucci syndrome, so all these are multiple lesions of cartilage, right? So enchondroma and osteochondroma, if you remember, the cartilage cap, whenever it turns into malignant, that is nothing but your secondary malignancy. So as the syndromes are important for us to remember, the questions may be framed asking what malignant changes is expected in this syndrome. So the answer would be chondrosarcoma. So that way it is important for us. The chondrosarcoma you have to remember, because you have remember all the syndromes, right? So this is Maffucci's syndrome. But what chondrosarcoma is mostly seen in pelvis. So whenever they put up a pelvis with lot of cartilage in it, and it is like extensive cartilage like this. So extensive destruction with lot of cartilage. Like how do cartilage appear? Like your puffy calcification, your comma-shaped calcification. So these are the calcifications which are seen in and around. So this is your chondrosarcoma. So this is your chondrosarcoma, right? So usually they put up the X-ray of pelvis. So chondrosarcoma is usually seen in pelvis or the proximal femur. So these are the important, like they are lovable sites for your chondrosarcoma. They are in, they love these sites, the pelvis and the proximal femur. So that is your chondrosarcoma. Then coming to chordoma. So what is chordoma? So chordoma is usually seen in sacrum or the base of the skull. So what is important in chordoma? The origin, the falciferous cells, which is again seen on the biopsy. So the origin of the cell is, this is called as the falciferous cells. But usually chordoma is seen in the sacrum and base of the skull, and usually because the sacrum is one such area where we can't do surgery. So here the treatment of choice remains as radiotherapy. So this might be the question. So they can frame a question asking that what is the treatment of choice in case of chordoma in sacrum? So it is radiotherapy, somewhere related to brachytherapy, right? So that is the radiotherapy where you can't reach that site for operating. So it is usually not amenable for operating, so we go for radiotherapy as treatment. So that is about chordoma. Then what you have to remember is the metastasis. So metastasis, what you remember is the secondaries, the very important secondaries you have to remember. So here there are two types of secondaries. The secondaries can be lytic, the secondaries can be blastic. So whenever I say lytic and blastic, so lytic you have to remember the breast mainly, right? And blastic, what you remember is the prostate, right? So these are two important things what you have to remember. Whenever I say blastic secondaries, it goes in favor of prostate carcinoma, but the prerequisite, it should be in males, right? So obviously, so males, prostate is seen in males, so whenever they are blastic secondaries, it is the prostate carcinoma. And lytic is mainly seen in case of breast, that is in females. Again, it is already framed in your mind that it is usually in the females. Whenever you see secondary metastasis, lytic lesions, it is about the breast carcinoma. But where do you actually see this? So usually the area is your vertebrae. So you have to check for vertebrae. So everything is vertebrae from cervical to sacral. Which vertebrae you check? You check for the dorsal vertebrae. So this is the area where you see. So the dorsal vertebrae is commonly involved in case of your secondaries or metastasis, and blastic and lytic. Blastic is mainly in case of males, that is prostate carcinoma, and lytic is females. What are the other three carcinomas where you can expect the secondaries in bone? So one is your renal, the second one is your thyroid, and finally mixed lesions are seen in your lung. So these are the 5 important things: the prostate, the breast, renal, thyroid and lung. These are the carcinomas where they produce secondaries in the bone, right? And where you check for secondaries in the vertebrae, especially the dorsal vertebra. So that is much, if you remember, it is well good. And what is the one important criteria you have to remember? So that is called the Merrill's criteria, just for your fixation. So if you want to remember extra knowledge for extra marks, so remember that there is a criteria which is called as Merrill's criteria. Based on that, they go for fixation of that particular secondaries. And then what about osteoblastoma? What you have to remember about osteoblastoma? So osteoblastoma is nothing but it acts as a differential diagnosis for your osteoid osteoma. So it acts as a differential diagnosis for osteoid osteoma. If you remember, the nidus which I told you for osteoblastoma is 1.5, right? So the nidus is less than 1 centimeter, right? Here the nidus will be more than 2 centimeters. So whenever you see a nidus of more than 2 centimeters, then you have to think it as osteoblastoma. But osteoblastoma is usually seen in vertebrae, the posterior elements. So the favorite site is your posterior elements of your vertebrae for osteoblastoma. And then non-ossifying fibroma. Non-ossifying fibroma is an interesting thing. Why it is so interesting? Because it is again an incidental finding, and it has no role except for confusing us. So it is just a confuser. So there is nothing to do with it, but you have to still be careful whether it could be something else. So again, it is seen usually in the diaphyseal region. So this is your non-ossifying fibroma. So this is the non-ossifying fibroma. See, this is something confusing, right? So it is looking like that. So but this is a non-ossifying fibroma usually seen in tibia, the lower end of tibia. Just remember, sometimes there are certain bone infarcts, bone islands, non-ossifying fibroma. These are all just to confuse us, the confusers which are present. So these are again the incidental finding. The patient comes with so-and-so pain, and you take the x-ray, you find this, and you give NSAIDs, and then the pain get reduced, right? If it is not reducing, then you can think of other things, right? So this is about the tumors, very, very important, and at least one question is asked every time from the tumor. So I hope I have completed much of it. And then the next important question which you are going to answer is about all your nerve injuries, right? So this is the very high yielding topic. So I see some people, but I want you all to answer also. So if you interact, then it will be more efficient for you. Okay, so if you remember, in case of nerve injuries, there are three important nerves, right? So what you have to remember is the median nerve, the ulnar nerve, and the radial nerve. So what you have to remember in them are they basically, they ask you only about the test. They will test your test knowledge on it, right? So there are various tests which are there. If you remember all these tests, you're done with the nerve injuries, you're sorted. So before that, what you have to remember is the nerve supply. So you have to remember that what it supplies, that plays a very important role. So once you remember what the nerve, what muscles are supplied by each nerve, then it becomes easy for you to remember, right? So median nerve, if you remember, it supplies all the flexors and the thenar muscles, right? This much if you remember, it is fine, good. Flexor and the thenar muscles. Coming to the ulnar nerve, it supplies the FDP and your FCU. So half of FDP and FCU, and it supplies the hypothenar muscles, and it also the interosseous muscle and your lumbricals. So the lumbricals are the the third and the fourth lumbricals are by the ulnar nerve. Here again the lumbricals, that is your first and second lumbricals. So first and second lumbricals, here the third and fourth lumbricals for the ulnar nerve. And very important, the radial nerve, it supplies all the extensors. So there is no confusion. Extensors is radial nerve, which has made our life easy. So extensor is by the radial nerve. Ulnar nerve, you know, that is, this is your ulnar part. So little finger part, all this side is your ulnar nerve, and your thumb part all is your medial nerve. So the tests are also like that only, no? Anything which is related to thumb, the index finger, it is all medial nerve. Something related to your little finger is all ulnar nerve. Something related to your extension, it is radial nerve. This is at least simple for you. Okay, now let us see what is, so there are certain principles which you have to remember. The one thing which you have to remember is this ulnar nerve, it supplies one adductor pollicis. So this adductor pollicis, whenever I say pollicis, that means it is a thenar group of muscle. So this ulnar nerve will supply this thenar muscle, which has given rise to one important test, which is called as the book test, right? So when you see this book test, it is nothing but you need a book. So you have to hold a book. So whenever I give something for you to hold like this, so imagine this is a book and I'm asking you to hold with your thumb. So you use this thumb to hold. So this is nothing but your adduction. So use the adductor pollicis to do. But whenever there is a weakness of the ulnar nerve, so your adductor pollicis is not working, then what you do? So what you do is you will not leave the book, but you will try to hold the book, but using your flexors, right? You hold the flexors. So this flexors is supplied by the median. So whenever you see that there is a flexion or bending in the thumb, that is called which sign? That is called your Fromen's sign. So that is called your Fromen's sign. Yes, that is called your Fromen's sign. So adductor pollicis, book test, Froment sign. So they have asked enough time that the book test and the Froment sign, but now it is time to test your knowledge of which muscle. So that this time they may ask you about your adductor pollicis. So that is about the ulnar nerve. So I have told you whenever it is related to any thumb or the index fingers, this is all about your median nerve. So let us see what are those important tests for median nerve, because it applies all the flexors of on the medial side, on the lateral side, that is on the thumb side. So first one is your ape thumb deformity. So this is your ape thumb deformity, where you see usually the thumb is perpendicular to the palm. So this is where the humans have evolved from the apes. So apes, it was in line with all the fingers, but humans, as the evolution, we have got the thumb perpendicular to the palm. So again, going back to your ape, that is whenever there is a median nerve palsy. So this is a ape thumb deformity, and I told you again the test for your thumb. So whenever there is one more important function of the thumb, that is your opponent's pollicis. That means touching all the fingers, that is the tip of the fingers. So whenever you put a pen and then you want to touch it, so from this position it is coming and touching the pen. So this is called the pen test. So pen test, ape thumb deformity, ape thumb, and your pen test is for your median nerve. And then again I told you, again the middle and the index are by your median nerve, right? So here what happens is flexors. So whenever you're seeing that, test for flexion, nothing else. You have to just ask them to flex. So how do you ask them to flex? You ask them to make a fist. So this is nothing but flexion. Now what you are asking them to do like this, a fist. But here what happens, because there is a lack of the flexion, the index finger is not flexing. That is nothing but your pointing index. So whenever the word index, whenever there is a word thumb, think about your median nerve, right? And then what is this? So again, similarly, you're asking to do single fist. So here they are able to not, so as these two are supplied by the ulnar nerve, they're completely flexing. This is half and half. So this is little bit flexing. So index finger is completely not supplied. So this is something is called the Pope sign. So usually the Pope, the Christians, the church, the Pope. So usually they put the finger, the hand in this position while they give the speech or they do, and this is also called as the benediction sign. So this is also called the benediction sign, the Pope sign or the benediction sign. And now coming to very important sign, it is very important to appreciate others, but this is done by your anterior interosseous nerve, which is not very special. It is nothing but your baby of your median nerve. It is a branch of your median nerve. It is anterior interosseous, right? How do you remember it? Anterior is this side, right? So these are our flexors. So this is anterior side. So anterior side is all median nerve. Posterior side is all radial nerve. So posterior interosseous nerve is a branch of radial nerve. Anterior interosseous nerve is a branch of median nerve. Very good. And what is this? So anterior interosseous nerve supplies these muscles which make you perfect oval shape. So this is perfect oval shape, telling it is okay. So whenever you're unable to make this okay sign, it means that there is an anterior interosseous nerve deficiency. Okay, Surya, it is a pincer grip you're talking about? Yes. Good evening, Daniel. So this is the okay sign, and it is also called as 𝐒𝐿𝐿 sign. So this is okay or the 𝐒𝐿𝐿 sign, right? I'm going a little bit fast because this is revision, nothing to write, just speak to yourself, answer to yourself, okay? So we have done with the median, so ape thumb. So again, talking about thumbs and your index fingers is all median nerve, because this is all median nerve, and you remember the flexors are on the anterior aspect, hence it is also anterior interosseous nerve. So this is nothing but your ape thumb deformity, the pen test which you do with the thumb, the pointing index, again your median nerve, the benediction sign. So this is your benediction sign, again nothing but pointing index, and this pointing index is this plane, and this is this plane. So same, anything is same, right? Then again we have discussed about your okay sign or the 𝐒𝐿𝐿 sign. So this is about your median nerve. Now coming to the ulnar nerve. So ulnar nerve, as I told you, this is on your medial aspect. So because this is the position of your anatomical position, right? So ulnar nerve comes to on the medial side, where it has both your ring and your little finger. So whenever there is some abnormality in the ring and little finger, it is all about your ulnar nerve. So the first thing what you see is your claw hand, and this claw hand is called your partial claw hand. So this is called the partial claw hand, right? And this is seen in the ulnar nerve. What are the tests related to it? So first one is, as we already know, that pad and dab, right? So what is pad and dab? These are for the Palmar introitiate, dorsal introitiate. Palmar for adduction, dorsal for abduction. So pad is adduction. It is the card test. So holding the card is again by adduction. What is DAP? Adduction. It is nothing but your 𝐒𝐿. So testing for the abduction. Testing for the abduction is 𝐒𝐿. So you have testing for this movement. So you're moving away. So this is abduction. This is adduction, right? So card test and your 𝐒𝐿. Here what is important in case of ulnar nerve is what is the splint which we use. So the splint here is your knuckle bender splint. So this is your knuckle bender splint which you have to remember. So this is your knuckle bender splint. So knuckle bender splint is used for your ulnar nerve palsy. We have already discussed about the book test. Book test is again, if you remember, thumb. It is related to thumb, right? So thumb is again your median nerve. So whenever you see usage of the thumb inflection, it is your Froment sign positive. It is seen in case of ulnar nerve palsy, where adductor pollicis is applied by your ulnar nerve, even though it is a thinner group of muscle. That is about your test. Coming to the radial nerve, this is my favorite nerve because there are no tests which are involved in it, but you have to understand that there is an important issue underlying it, that is your Saturday night palsy. Very, very important, because whenever there is a Saturday night palsy, what is the Saturday night palsy? This is nothing but there is a usually what we do on the Saturday nights, not in India, in the Western countries, usually they booze or party on the Saturday nights. And whenever they take this position, after having heavy drink, they sleep on the chair with this chair hitting onto your axilla, there is always damage to your radial nerve, and next day morning they get up with what is this? This is your wrist drop. So next day morning they get up with the wrist drop. What is this drop? So they are unable to maintain the extension of the wrist. So hence this is considered as a drop. So this is called the wrist drop. Yes, this is the wrist drop usually seen in case of radial nerve palsy. But now tell me, what is this Saturday nerve palsy according to nerve classification? Is this a neuropraxia or axonotmesis or a neurotmesis? That is what I want you to answer. So is it a neuropraxia, axonotmesis or neurotmesis? Give me the answer fast. So before that, I'll teach you what is this fracture. So this fracture is a fracture of which bone? This is humerus bone, right? So fracture of the humerus, and usually in which area? So this area is somewhat, this is most like, so if you divide, this is the most proximal, this is middle and the distal, right? So proximal 1/3, middle 1/3 and distal 1/3. So this is in between. So this is proximal 1/3, middle 1/3 and distal 1/3. This is somewhere in between the junction of the middle and the distal third. So this is called as the Holstein-Lewis fracture. So this is called the Holstein-Lewis fracture. Again, whenever there is an Holstein-Lewis fracture, there is always a damage to the radial nerve, because radial nerve is present at that groove. So that is the radial nerve which is damaged there and resulting in the wrist drop. This is very important. They have asked you recently. This is called the Holstein-Lewis fracture or Saturday nerve palsy. And the type of nerve here is, no, this is neuropraxia. So this is neuropraxia. So why it is called neuropraxia? Because there will be no damage, exact damage to the axon or the myelin sheath in case of this Saturday nerve palsy, right? So what happens is there is only conduction block. So whenever there is a conduction block, this is called as neuropraxia. And now you can assure the patients that this is 100% recovery is seen. Hence this is an important thing which you have to remember, that there is 100% recovery in case of your neuropraxia. Right? Very good, Surya, you have at least attempted it. And now what you do whenever you see the wrist drop? You either treat it, with the splint. So why splint? So you have to put your muscles and tendons to contraction. You can't just leave them like that. Now they become they become very, again, even the nerve is coming back, like the radial nerve is coming back, the tendons and the muscles has to be intact so that they again start working. Right? So there are two types of splints. So one is called the cock-up splint. The second one is called the, so this is the static cock-up splint and this is called your dynamic cock-up splint. Yes, very good. So one is the static, the second one is your dynamic cock-up splint. How do you identify in the exam? So in the exam you see that the static, there is no spring, but whenever you see the spring over the your cock-up splint, that is, the spring is used for the action, so it makes the flexion and extension of the finger. So whenever you see the spring, that is your dynamic cock-up splint, and there is no spring attached, it is your static cock-up splint. Fine. And you can get confused with the VIC in case of your static cock-up splint. So VIC also is similarly like this, but you see there is a spring down here. So spring is present on this aspect, the volar aspect for VIC, but there is no spring is seen on the static cock-up spleen. That is what you have to remember. So the radial nerve, two indications where you can see in case of your Saturday nerve palsy or Holstein-Lewis fracture, and there is a wrist drop, and there are two important spleens, the static and the dynamic cock-up spleen, which you have to use in case of your radial nerve palsy. And what is this sign? So this sign is nothing but your Tinel's sign. So this is your Tinel's sign. What is the Tinel's sign? So Tinel's sign is nothing but whenever there is a nerve damage. So in case of, there are three, right? Neuropraxia, axonotemesis, and neurotemesis. So what do you mean by neurotemesis? There is a complete transaction of the nerve. So complete transaction of the nerve, there is only block, conduction block, and axonotemesis is axon is damaged. So what happens is whenever in neuropraxia, the Tinel sign is negative, and in case of axonotemesis, what happens is there is a myelin degeneration, right? So there is a myelin degeneration. So this is called as the Wallerian degeneration. So there is a Wallerian degeneration. Because of this, the nerve can again recover. So whenever there is a recovery of the nerve which is happening, that is called as axonotemesis. In case of axonotemesis, there is a nerve recovery which is happening, and this you can elicit by the Tinel's sign. So Tinel's sign is positive and progressive in case of your axonotemesis, whereas in neurotemesis it is positive but not progressive. Positive but not progressive. So that is about your Tinel sign, right? So how do you elicit this Tinel sign? You're going to tap on the particular nerve from distal to proximal. So from distal to proximal, so whenever you see the nerve fibrils coming out, so there you experience, there is a shock like thing which happens. So this is your Tinel's sign. So this is also used in your carpal tunnel syndrome also, right? So this is a very important sign which is elicited in case of nerve injuries or nerve damage, right? So what you have to remember is you are going to tap upon that nerve, and then if there is a recovery or if there is a something related to nerve, then the patient experiences a shock like sensation over the entire region where this particular nerve is supplied. So that is your Tinel's sign. And what is this? So this is very, very important. That is the sensory distribution of, again, your ulnar, your median, and the radial nerve. So as we discussed, so median is again by 3.5 fingers, ulnar is again your 1.5 finger, and this is your radial. So radial is only, dorsal part is radial, and this small part here is your radius. But what about your autonomous zones? This is also again important. Autonomous zone is, this is for the radial autonomous zone, this is for the ulnar autonomous zone, and this is for your median autonomous zone. So you have to remember the tip of the index is for the median. Autonomous zone is nothing but it is exclusively for the median nerve, where there is no overlap of other nerves, right? So this is, if this particular area there is a sensory loss, that means there is a median nerve damage. Similarly, the autonomous zone for little finger is on the tip of the little finger. For the ulnar nerve is the tip of the little finger. And similarly, the autonomous zone for the radial nerve is over the tip of your thumb. So that is about your sensory distribution. So as we are talking about the various tests like the book test, the card test, the IGAVA test, the pen test, and what are these two important tests which are again elicited in case of your upper limb. So this is your Cosen's test. So this is your Cosen's test. So what do you mean by Cosen's test? This is seen in case of your tennis elbow. So this is your Cosen's test seen in case of your tennis elbow. What is tennis elbow? This is nothing but your medial epicondylitis. So in the elbow you have to medial and lateral epicondyle. So whenever there is a, lateral epicondylitis, tennis elbow is lateral epicondylitis. So lateral epicondylitis, so that is on the lateral side. So this is the lateral epicondylitis. So whenever there is an injury to the extensor carpi radialis brevis, so this is the tendon which is involved, and whenever there is a damage or some overuse of this tendon, there will be pain on the lateral aspect of the elbow. And how do you elicit the lateral epicondylitis? So you do this Cosen's test. So you stabilize the elbow, then you ask the patient to extend the wrist. So whenever they're extending the wrist, they have this pain over this lateral epicondyle. So that is called the Cosen's test in case of your tennis elbow, right? And then what is this test? So here you see there are two important tendons in your first extensor compartment, right? So the first extensor compartment, you have two tendons. So there are the one is the APL and EPB. APL and EPB. So there is no confusion. Lateral epicondylitis is tennis elbow. Medial epicondylitis is your golfer's elbow. So medial epicondylitis is golfer's elbow and your lateral epicondylitis is tennis elbow, right? So for the tennis elbow you have your Cosen's test, and for golfer's elbow you have your reverse Cosen's test, right? So reverse Cosen's test for your golfer's elbow. Then coming to the this particular image. So here what happened is there are two important images, right? So these two images are APL and EBB, right? There are abductor pollicis longus and extensor pollicis brevis. These are the tendons of the first compartment. So the extensors of the first compartment, that is APL and EPB. This is called the Finkelstein test. This is called the Finkelstein's test. So this Finkelstein test is for your which important conditions you have to remember, that is de Quervain's tenosynovitis. So this is de Quervain's tenosynovitis. So this is very important question. So you have to remember is the test name. So one is your Cosen's test, which is seen in tennis elbow. The second one is your Finkelstein's test, which is seen in your de Quervain's tenosynovitis. So how do you do it? Again you extend. So make a fist like this. Make a fist and again you try to extend it against resistance, right? So whenever you're trying to extend it against resistance, then there is a pain over your first compartment of the tendon. So you try to do this. So you try to extend it on resistance. So on extending it, you will have APL, EPB tendon tenosynovitis, right? That sheath which is covering this tendon is inflamed. Hence they produce this pain. So this is called as Finkelstein's test. That completes your test. And now this is again an PYQ which is very recently asked in the NEET PG. So there's a X-ray which was given, so stating that to identify the nerve which is damaged. So usually what they tell is the fracture neck of fibula. Neck of fibula, where you see there is a common peroneal nerve. So there is a common peroneal nerve which twists around this neck of the fibula. So whenever there is a fracture neck of the fibula, you see there is a damage to this common peroneal nerve which might result in what is called as foot drop. So it results in what is called as foot drop. And what do? You splint it. So this is called as foot drop splint, right? And what is the gait which you see in foot drop splint? This is called the high stepping gait. So why it is a high stepping gait? Because lack of the dorsiflexor. So whenever there is absence of the dorsiflexors, the foot is dropping like this, and you have to lift the foot and then put it. You have to lift the foot and then put it. So this is the high stepping gait which you see in your foot drop. And what is the splint? So this is your foot drop splint. And when you use this, you use in case of your whenever there is abnormality in the fibula neck. So there is a common peroneal nerve which is taking a turn around the neck of the fibula. So in case of fibula fractures, you have to check for this particular CPN, right? So that is about this common peroneal nerve. And then what is this area which is called? This is also important area. This is called the regimental badge area. So this is called the regimental badge area. Why it is called the regimental badge area? Because in the army, in the in that particular area, they put the badge at this particular deltoid region. So on the deltoid region, there is small patch-like area which is supplied by which nerve? So this is supplied by your axillary nerve. So axillary nerve is supplies two important muscles. One is your deltoid muscle and the second one is your teres minor, right? So the deltoid is used for your abduction. So abduction is limited and teres minor is external rotation. So these two are affected. And the sensory loss here, this is the sensory loss. So sensory loss is seen in which area? Sensory loss is related to regimental badge area, which is due to axillary nerve palsy. So axillary nerve palsy, you see this particular area which is hypoanesthesia is seen in this particular patch area which is called as regimental badge area. And what is the nerve which you have to remember? That is your axillary nerve. So what is the action of the deltoid here? So the action of the deltoid is abduction. So here the patient presents with loss of abduction, and the sensory loss is seen in this particular area as the IBQ, and then they will ask you which nerve is involved. So the nerve which is involved is your axillary nerve. Yes. And now coming to the brachial plexus. So very important again, brachial plexus injuries. So there are two important injuries which you have to remember. So one is your Erb's palsy. The second one is your 𝐒𝐿𝐵 palsy. So what is Erb's and what is 𝐒𝐿𝐵? So 𝐒𝐿𝐵 palsy and Erb's palsy. Erb's palsy is your upper trunk which is damaged, right? Upper trunk, and what you can see here, what is the deformity? So upper trunk, if you remember the various C5, C6, that is again axillary nerve, and it also supplies the musculocutaneous nerve. Hence you see what? Adduction plus internal rotation in case of your shoulder, and pronation and extension because the musculocutaneous nerve is involved near the elbow. So this is the deformity, resulting in what is this called? Policeman tip deformity. So this is called as policeman tip deformity, where you see, yes, very good, it is policeman tips deformity, where you see what are the deformities. So there is adduction and internal rotation. So the shoulder is adducted and it is internal rotated because the axillary nerve is damaged again. So usually the axillary nerve, what is the function of it? It causes abduction and external rotation, but because this is damaged, it results in adduction and internal rotation. And similarly, the upper trunk also supplies the musculocutaneous nerve. So musculocutaneous nerve supplies the flexor. So flexors are absent here. So now the elbow is going to extension and pronation. So these are the deformities which you see in your Erb's palsy. Adduction, internal rotation with pronation and elbow extension, resulting in your policeman tip deformity. That is your upper trunk which is damaged. Coming to the 𝐒𝐿𝐵 paralysis, it is the C8 and T1. That is your lower trunk which is damaged. And what happens here? You see the complete claw hand plus flexion of the elbow. So flexion of the elbow with complete claw hand. What you see? This is 𝐒𝐿𝐵 palsy, the C8 and T1. That is your lower trunk which is damaged, right? So this is about your obstetric the brachial plexus injuries. And what is the splint which you use? The splint used in this is called the aeroplane splint. So this is called as the aeroplane splint, right? So you put the shoulder in abduction and elbow in flexion at 90 degrees. So this is the aeroplane splint which is used. So that is Erb's palsy and 𝐒𝐿𝐵 palsy, right? So this is about the various nerve palsies. So whenever it is brachial plexus palsy, you have to see whether it is preganglionic. So somebody has raised about Horner syndrome. When you see it is preganglionic, it is associated with the Horner syndrome, right? So that means the root has avulsed. So this is root as avulsed. So it is associated with meiosis and hydrosis, right? So ptosis, meiosis and anhydrosis is Horner syndrome. And when this is associated with the preganglionic injury, you will see these features of Horner syndrome in case of brachial plexus injury. Fine. So very good. And now moving on to the next chapter, that is your joint disorder. So we have completed the tumors, the nerve injuries. Then two important joint disorders which you have to remember is one is osteoarthritis, the second one is rheumatoid arthritis. What is mostly differential thing is between these two are, this is use. So degeneration, as we use, the overuse or the abuse of the joint will result in osteoarthritis. But coming to the rheumatoid arthritis, it is inflammatory. So as I told you, degeneration, as we use it, so it is usually seen in elderly. This is usually seen in young. Because this is inflammation, it is always bilateral. It can be unilateral or bilateral. That means it is asymmetry. This is symmetrical, right? Symmetrical. So that is the main thing. And usually the inflammatory things are seen related to females, so pertaining to females. So whenever you see a question which is framed related to females, young females, and what are the important words which you have to remember? The important words here are morning stiffness. So the morning stiffness is one word with the multiple joints. That is the polyarthralgia. So whenever you see multiple joint, warning stiffness, young female, bilateral, symmetrical, all this terminology will clinch you to the diagnosis of rheumatoid arthritis, right? So when you see an elderly, asymmetrical, and usually they complain pain at the end of the day. So as the day progresses, they have this pain at the end of the day. So they present pain in the evenings, right? So that is how you come to a diagnosis of degenerative arthritis. So these are the two important things which you have to remember. But coming to the X-ray version of it. So X-ray, what you see? Usually we see that there is loss of joint space. So because the degeneration is starting in the joint, where first there will be damage to the cartilage and then there will be bony erosion. So first there will be loss of the joint space, and then the second one is subchondral cyst. The subchondral cyst is in favor of mostly the osteoarthritis. So subchondral cyst, and in both you see there is a subchondral sclerosis. Subchondral sclerosis, but cyst is usually seen in case of your osteoarthritis. So these are the cysts which I was talking about, the subchondral cyst. Why are this cyst forming? So whenever there is a joint, there is a synovial fluid. So what happens is first the cartilage is eroded, then the subchondral bone is eroded, and now this fluid gets seeped into the bone. The subchondral bone, the fluid gets seeped, and this forms the cyst around it. So this is about the cyst, subchondral sclerosis, and you see there is a deformity, right? So usually it is the varus deformity of the knee which is seen, in case of your osteoarthritis. So these are the certain important points. So first you see there is a loss of joint space, and then you see there is a subchondral cyst, and you see subchondral sclerosis, and you see the deformity. So this is all about your osteoarthritis. Coming to the rheumatoid arthritis, what you see? So rheumatoid arthritis, what you see is first, similarly there is loss of joint space, but that is naturally seen in both. And then here what is important is periarticular osteopenia. So there is osteopenia which is seen. That means there is a lucency over the articular region. So you identify the joint, and above and below that joint you see this lucency which is called as periarticular osteopenia, which is very, very specific for your rheumatoid arthritis. And whenever you see joint damage, it is usually symmetrical. In case of rheumatoid arthritis. And this subchondral sclerosis, it is also seen in case of your rheumatoid arthritis. But sclerosis is specific, cyst formation is specific for osteoarthritis, and then your periarticular osteopenia is specific for your rheumatoid arthritis. Yes, the sparing of the wrist and MCPs are usually seen in case of your so rheumatoid arthritis, MCPs, the joints, if you take the joints in both, this is the CMC joint which is usually involved, and here these are the MCP joint. So MCP joint and the PIP joint and the wrist joint, these are the joints. So the smaller joints are also involved in case of your, yes, very good. There is pairing of MCP which is seen. So in case of rheumatoid arthritis, what you have to remember is the MCP is mostly involved with the PIP and the wrist joint. What is the DIP is usually spared. In case of rheumatoid, it is the DIP which is usually spared. This is very, very important. So DIP is usually spared. But in case of your rheumatoid, the CMC is mostly involved. In case of your osteoarthritis. Now, what is the exam-based question here? So exam-based question, what you have to remember is there are two important nodes. One is called the Bouchard's nodes, and the second is called the Herbedens nodes. So where you see this and this. So how to remember? This is HD. So high definition quality, the photographs of the video, we send it through the high definition, and then BP. So HD and BP. So HD is for Herbedens, which is seen in DIP, and Bouchard's is for PIP, right? So this is very, very important. How Herbedens node is seen in PIP, right? And Bouchard's is seen in PIP. This is what you have to remember. Right? So Bouchard's and Herbedens, remember HD and BP. Herbedens node is seen in distal interpharyngeal joints, and whereas Bouchard's B is seen in P, that is proximal interpharyngeal joints, right? Okay, you can, yeah, heart disease and blood pressure. You can remember is that way also. Surya has made it little easy for us, heart disease and blood pressure, right? Then what about this rheumatoid arthritis? So rheumatoid arthritis is also very, very important in case of deformities, because the hand involvement is more in case of rheumatoid arthritis. There are various deformities which you have to remember: the Boutonniere deformity, the swan neck deformity, and you see there is ulnar deviation to one side, ulnar deviation of the MCPs and wrist deviation to the radial. So this is called as the Z deformity. So it's a Z deformity, and this particular Z deformity is also seen in thumb. So these are various deformities which you see. So how do you remember the Boutonniere's deformity and the swan neck? So swan neck deformity is nothing but the flexion at the DIP, right? And the Boutonniere's is nothing but flexion at the PIP, right? So how do you remember is, so savings, so savings usually we do by FDs, right? So FD, fixed deposit. So remember the swan neck is seen flexion at the DIP, right? And when it comes to Boutonniere's, buying something, you usually do the PIP, right? You pay it. So BP, again you have to remember the Boutonniere's is for flexion at the PIP. Fine. The swan neck is flexion at the DIP. So this is your swan neck deformity, where you see flexion at the DIP and opposite, that is extension at the DIP. So that is how you remember the swan neck deformity. So one you remember, I think the next one is exactly opposite to it. So remember swan neck, that is remember savings for FD, right? So flexion at DIP. So the contrary is that extension at PIP. So exactly opposite to that is your Boutonniere's deformity. So along with that, you have to remember that there is Z deformity. Z deformity is something like the opposite. So ulnar deviation of the MCPs with radial deviation of the wrist. So that is the thing which you have to remember. And in case of the toes, what you see is the hammer toe. So hammer toe in case of the toes. So fingers, you have swan neck, Boutonniere's, Z deformity, and then you have only ulnar deviation of the MCP or only radial deviation of the wrist, or Z deformity of the thumb, and then you have hammer toe. These are all the various deformities which you see in case of your rheumatoid arthritis. Fine. And then coming to treatment of this. So treatment of any arthritis, if it is in stage 4. So stage 4 means there is a severe deformity. So severe deformity, what do you treat? The treatment is total knee replacement. So the treatment here is total knee replacement. So this is the picture of the total knee replacement, where you change the femoral component and the tibial component, and in between the cartilage action is done by this poly. So this is called the poly. Okay, so this is the poly. So you have the femoral component, the poly, and the tibial component. So this is the total knee replacement TKR. Similarly, for the hip, we have THR, that is total hip replacement. So that is THR. So that is about your osteo and the rheumatoid, only the important things. Next, coming to the very, very important one, this is called as your ankylosing spondylitis. So this is related to the spine. And here, what are the important words which you have to remember is, this is usually seen in young and this is usually seen in males, and it is associated with HLA-B27. So this is the genetics which you have to remember in case of ankylosing spondylitis, that is, it is related to HLA-B27 gene. Right? And what is very, very important for diagnosing ankylosing spondylitis? The involvement of sacroiliitis, and that too bilateral sacroiliitis. So there is an involvement of this particular joint which is called as sacroiliac joint, and this involvement of bilateral sacroiliac joint plus the spine will end up you landing in the diagnosis of ankylosing spondylitis. So what is the first test which you do to observe the damage to the ankylosing spondylitis? This is the Faber's test, or the figure of 4. So this is the first test which you do as a person comes who is a young male patient with genetics HLA-B27, and now they complain about, what are those complaints? So complaining about morning stiffness of the spine. So morning stiffness of the spine, whenever the person complains, is nothing but you have to examine him for ankylosing spondylitis. So what do? You do this Faber test. So this is the Faber's test, and this is the X-ray which shows there is an involvement of the SI joint. So what do you see in this? So there is, you can see the effusion, or there is a decrease in the joint space. decrease in the joint space, which tells you that there is an involvement of sacroiliac joint. But as this is progressing towards the spine, what happens is there is a formation of multiple osteophytes. So these are called the multiple osteophytes, which are called the syndesmophytes. So these are called the syndesmophytes. So these are syndesmophytes because syn is nothing but fusion, and they're seen entire spine, resulting in, this is called as a bamboo spine. So what happens whenever there is an entire fusion of the spine? So what is actually the basic function of the spine? We flex the spine, right? We flex and extend the spine. So bending movement is possible, right? So this bending movement is absent in case of people with ankylosing spondylitis because the spine is involved entirely forming syndesmophytes, and another one is enthesis. That is, whatever the ligaments and tendons which are attached to the bone, they are calcified. So all the ligaments and tendons attachments are calcified. Hence, this calcification of the posterior longitudinal ligament is seen as your dagger sign. So these two are very, very important. The dagger sign is seen in ankylosing spondylitis. The syndesmophytes, along with the fusion of the entire spine relating or giving you the appearance of bamboo, is seen in your ankylosing spondylitis. So dagger sign and bamboo spine, both are seen in case of ankylosing spondylitis. And what is this particular test? To test the flexion of the lumbar spine. So flexion of the lumbar spine is tested by this test, which is called as your Schober's test. So this is called your Schober's test, where you ask the patient to bend forward. So first, initially you identify this dimple of Venus, that is, and you mark about 10 centimeters, and then you ask to bend. Now this should be more than 15 centimeters. If there is less than 15 centimeters, that is, the flexion is restricted. So that is called your Schober's test positive. Then you have to think about your ankylosing spondylitis. And one important feature what you have to remember is, with ankylosing spondylitis, there again the extra articular manifestations, like there is an involvement of eye, which is called as uveitis. Then there is involvement of pulmonary, that is lung complications. So again there are involvement of cardiac complications. So this is again extra articular manifestations are also seen in case of your ankylosing spondylitis. So the question goes this way: a patient, young male, presenting with morning stiffness, especially in the back, and then he has presented with uveitis, and then their chest expansion is decreased. So you have to be very careful with the chest examination, where you see a decrease in the expansion. So there is a decrease in the expansion of the chest, the limiting of the expansion of the chest, which again route you towards your ankylosing spondylitis. Okay. So that is the important thing, very, very important, and I have dedicated the entire slide to it. It is very, very important. Recently asked the two things, the dagger sign and the bamboo spine, right? The Faber test and the Schober's test. And the next one, so these are other different articular disorders. So let us read each in little detail. So first one is, so this is the pencil in cup appearance, and as I tell this name, the pencil in cup, I know you all will point out towards the DIP. So whenever there is an involvement of DIP with the pencil in cup appearance, this is nothing but your psoriasis. So what you have to remember about psoriasis, the Casper's criteria, where they tell that the skin lesion should be present and there is involvement of DIP, and it is oligo-articular. So there is an oligo-articular involvement, and this is very, very important, that it is called the arthritis mutilans, where there will be destruction. So there is a lot of destruction which is seen in case of your joint. So it is oligoarticular, but arthritis mutilans is given, the terminology is given to psoriasis. The Casper criteria, involvement of DIP, the appearance on the x-rays, pencil in cup appearance. Fine. So next, coming to this, so this is nothing but the knee x-ray, where you see there is widening of the notch. So there is widening of your intercondylar notch, which you should think about the hemophilia. And there will be a lot of striations, and widening of the intercondylar notch is nothing but your hemophilia. I'm pretty sure that you know what is hemophilia. There is a deficiency of the clotting factor, right? And then whenever they show you the x-ray with the great toe involvement, so great toe involvement, and it is usually seen again in males, and they are supposed to be alcoholics. So male alcoholic with the first MTP involvement. MTP is metatarsophalangeal joint. So this metatarsophalangeal joint is involved, and this is nothing but your famous gout. So when you see this picture, it is gout. So what is gout? There is an increase of your monosodium urate crystals. So this is formed by the uric acid. So whenever there is an increase in uric acid, so this excessive uric acid will get settled in the joint, because nothing but the synovial fluid is nothing but the filtrate of the plasma itself. So the uric acid from the blood goes into the joint, which cannot be metabolized, hence it gets crystallized. So this is a crystalline disease. So this is a crystalline disease which is called as the gout, where on the microscope, the electron microscope, you see which is called the negative birefringent, and you see what is called the needle shaped crystal. So you see needle shaped crystals. So this is all about the gout, which you have to remember. So the question starts with the patient being a male patient who is an alcoholic, and he was complaining about pain in the first great toe, I mean the first MTP or the great toe, which is swollen and which is painful to him. And then on the examination, we send it to biochemistry, that is on the needle shaped crystals are seen, which is negatively birefringent. The answer is gout. Sometimes they don't stop asking here, they might go into the pharmacology of treating the gout, like the probenecid, the allopurinol, which is used. And sometimes again biochemistry can be added, so they can ask the enzymes which are inhibited in case of using these drugs. So that is about the gout. And what is CPPD? CPPD is nothing but it is pseudo gout. Pseudo gout means there is a deposition of this crystal phosphate, calcium pyrophosphate crystals have been deposited, and it is usually seen in case of knee. So whenever they give knee joint x-ray with something related to crystalline disease, it is your pseudo gout. So pseudo gout, it is positive birefringent, right? So pseudo gout is positive birefringent, and these are rhomboid shaped crystals. These are rhomboid shaped, but that is needle shaped crystal. So that is needle shaped, this is rhomboid shaped. This is calcium pyrophosphate deposition, and that is your monosodium urate crystal. So this is your monosodium urate. This you have to remember, monosodium urate crystals. And this is calcium pyrophosphate crystals, which is deposited, and usually it is deposited in the knee. That is the pseudo gout. Fine. So now what is this? So there is an excessive sclerosis. If you see, there is an excessive sclerosis on the x-ray. So this sclerosis, and whenever you see yellow teeth or this discoloration of the teeth, you have to always think about one important condition which is called as fluorosis. So fluorosis is where their fluoride levels are exceeded. So the increase of the fluoride levels will cause what? So if you go back to the metabolism, they form the calcium hydroxyapatite crystal. So the bone is usually in the form of hydroxyapatite. So here they form calcium fluoride crystal. So this calcium fluoride is not in favor of resorption. So this will not allow resorption. So bone is nothing but bone will form, then it gets resorbed, then it forms. So that is the dynamics of the bone. But when there is a formation of calcium fluoride, the resorption is absent. Hence it appears more sclerotic. And this yellow teeth is the indication of there is an increase in the fluoride levels of the body. In Andhra Pradesh, now it is Telangana, sorry. In Telangana, there is a district which is called as Nalgonda. There is an excessive fluoride, and the Nalgonda technique, which we have read in the intermediate, is used for decreasing this fluoride content in the water. So that is about the fluorosis. What you have to remember is excessive sclerosis. If everything is white in color, you have to always have this differential diagnosis of fluorosis in the mind. So that is about the various disorders like the osteoarthritis, the joint disorders. So the osteoarthritis, the rheumatoid, the gout, the psoriatic arthritis, and then we have the hemophilic arthritis, finally the fluorosis, right? So this is about the metabolic disorders. Now coming to the deformity. So what is this deformity? So you always know that the spine has certain curves. So we know the cervical lordosis, the thoracic kyphosis, and again lumbar lordosis, right? So this is the three curves which are physiologically present in the body. Now coming to this. So first thing what you see is the alignment. So here the alignment and disturb, which is the sideward bending. So this is your scoliosis. So this is your scoliosis. Whenever there is a sideward bending, this is called scoliosis. Whenever there is a forward bending, this is called kyphosis, right? So scoliosis and kyphosis. Very, very important question. So this is very, very important. So recently asked, the angle which is measured in case of scoliosis is your 𝐂𝐝's angle. So this is the 𝐂𝐝's angle which we measure. And why do actually we measure this 𝐂𝐝's angle? We measure because we have to understand whether it is going for the conservative or the surgical treatment. So based upon that, we will decide what is the treatment, right? So 𝐂𝐝's angle, again you will identify the curve. So this is the curve. The end point of the curve, you draw the two lines like this, and then you draw the perpendiculars to this line. So this is the 𝐂𝐝's angle, right? So this is the 𝐂𝐝's angle. So 𝐂𝐝's angle, whenever it is less than 20 degrees, you can observe the patient. If it is 20 to 40 degrees, you prescribe orthosis, and if it's more than 40 degrees, you go for surgery. So this is the importance of 𝐂𝐝's. So this is 𝐂𝐝's angle. So what is this? Is less than 20 degrees, 20 to 40 degrees, and more than 40 degrees. So 𝐂𝐝's angle is used for diagnosis of the scoliosis. So here you will see that scoliosis, there is some angle which is made by the spine curve. So this is the 𝐂𝐝's angle. And what is this? This is the research sign. So this is research sign. So what is research sign? Research sign is, you will understand that the iliac apophysis. So this is the iliac apophysis. So in iliac apophysis, if you see, this is nothing but the iliac apophysis, right? So you can appreciate the iliac apophysis here. So this is usually taken whenever you want to treat the scoliosis. So you will wait until the person is completely matured. So to understand that maturity, you will take the example of this. You will take the help of this iliac apophysis. So this is the research sign. So there are certain stages like 1, 2, 3, 4, and 5. So this research sign is mainly to understand the skeletal maturity of that particular individual. Whether this patient is still going to increase the curve or the curve progress has been stopped. Because usually at the skeletal maturity, the curve gets stopped. But when you take the help of this research sign, you will understand whether you have to operate it immediately or you still can wait for the curve to progress. Srinath, I just want to clarify that this is a revision series. I'm here not to explain everything in detail. If you want everything to be explained in detail, you can subscribe to PW Mandate, where you have every word which is explained in detail. This is for the revision series, where people are sitting only for 1 or 2 hours to complete entire orthopedics. So before you attend some sessions, please make sure that what is the inference of attending that session. This is not here to explain everything, and here I'm only trying to recall as many as questions possible, which will be helpful for the people who are writing exam just in 1 or 2 months, right? Okay, anyways, now we'll move on to the various braces. So this is the, as I've told you, that in case of 𝐂𝐝's angle, there is one curve, and in case of scoliosis, there is one angle, that is 𝐂𝐝's angle. Based upon that, you will give the orthosis. Like in case of less than 20 degrees, you just observe the patient. So in this observation, you can take the help of the research sign, or you can keep measuring the 𝐂𝐝's angle. In 20 to 40 degrees, you will prescribe orthosis to the patient, and in more than 40 degrees, you go for surgical treatment. So what are those orthoses which are used in case of scoliosis? So the first one is called the Milwaukee brace. So Milwaukee brace is nothing but, it is very, very important. So this is used to support in progression of the curve. So whenever the patient is having any pain or some discomfort because of the curvature, so you will prescribe what is called as a Milwaukee brace. So you have to remember that this is the Milwaukee brace which is asked in the exam. And now this is your Boston brace. So Boston brace is one which is again used for your scoliosis, but here you have this tube-like structure, right? This is like one tube-like structure where it is mainly given for the thoracic level. So this is mainly given for the thoracic or the DL, that is lumbothoracic level, you prescribe this Boston brace. And Milwaukee brace whenever it is extending into the cervical level. So whenever you want to control the cervical curve as well, you extend this up to the occiput. Like if you can see the head is also fixed, right? So this is the Milwaukee brace, this is cervicothoracic lumbar brace, and here this is only thoracic and lumbar brace, that is your Boston brace. And then what is this? This is called the Charleston brace, and this is usually given in the night time. So night time, this is, you can see there is a bend here. So this is the bend which you observe. So this is called the Charleston brace, and it is usually prescribed in the night time, right? This is usually prescribed in the night time. So these are the three important braces which you have to remember for the scoliosis. So the first one is the sideward bending, then you have to remember the angle, that is the Kopp's angle, and then you have to remember the recess sign which is used for knowing the maturity of the patient. And then the orthosis which is prescribed are the Milwaukee brace, the Boston brace, and the Charleston brace, right? So that is about the scoliosis. As we are understanding about the various braces, let us read few braces, just the image based question. So this is the halo brace. So this is your halo brace. So this is called halo brace or the halo vest, where you see that the head is entirely fixed in this splint, right? So the head is entirely fixed, where you want to fix the occiput and the cervical spine. This is the halo vest where you use, and this is the 4-post collar. So this is the 4-post collar. So here you see there are two, like this is the anterior. So these are the anterior and these are the posterior. So there are four pole-like structures. So these are called the 4-post collar, right? And this one is called the somi. This is your somi. This is sterno-occiput mandibular brace. This is called the somi brace. And finally, this is your talar brace. So what is this talar brace? This is nothing but again your dorsolumbar corset, which is used for tuberculosis. So whenever there is a patient with dorsolumbar level, there is a TB, then you go for this talar's brace. This somi is again for sternum and your occiput. So this is, the name suggests, like sternal occiput mandibular, right? And then the 4-post collar is again for various treatments of the cervical diseases, right? So just remember the name, that is enough. So cervical diseases or the cervical discomfort, if the patient is having any curve, any abnormality in the cervical spine, then you can go for this halo waist or the 4-post collar or the somi. And finally in the DL you have your talar's brace. So this is called the talar's brace, fine. And what is this? This is very frequently used. This is the cervical collar. So this is the cervical collar. We have two types of collar. One is called the soft collar, which regularly we use for people who are suffering from cervical spondylitis, right? So you have your old grandmothers at house where they present with spondylosis, cervical spondylosis, then you prescribe this soft collar, like there's just a collar around the neck. Then we have this Philadelphia collar. Philadelphia collar is, there is a hole in the collar on the anterior side. So this hole is useful for doing tracheostomy. So this is useful for doing your tracheostomy. So that is your Philadelphia collar. So you have to just identify the collars, right? And what is this? This is a famous splint which is called as your Thomas splint. So Thomas splint, very, very important question again. So this is your Thomas splint, which is used for the, yes, where it is used? It is used for immobilization. So immobilization of the femur shaft. So immobilization of the femur shaft, where you use, this is your Thomas splint. And what is this? This is your BB splint. So what is BB splint? BB splint is mainly multi-purpose, like it could be used for foot drop. So there are 3 rings, if you can observe, 1, 2 and 3. So this is the first one where you can use is for the foot drop. So whenever there is a foot drop, and the second one is femur shaft fractures, right? So the first femur shaft, and then so this is, and this is for your femur shaft fracture, and this is again for your any upper limb fractures, right? So if you want to immobilize it, if you want to immobilize the patient with the foot drop and upper limb fractures, like sorry, not the upper limb fractures, the lower limb fractures, the femur shaft and the tibia, upper tibia. femur shaft and the upper tibia. So this is the Bowler-Brown splint. So this is called the Bowler-Brown splint. So this is called the Bowler-Brown splint. So in case of BB splint, we have three. So first one is for the foot drop, the second one is for your tibia, and the third one inline is for your femur fractures, right? So that is the BB splint. You have to identify that this is the BB splint, okay? So this is your Thomas splint and this is your BB splint, fine? And now coming to these two important fractures. So here we have the fracture, and if you see, if you can observe, there is certain abnormality in it. So there is a lytic lesion and which is associated with the fracture. So this is nothing but a pathological fracture. So this is nothing but your pathological fracture, right? So whenever you see such pathological fractures, you should always be careful that you have to first diagnosis from which pathology is this happening, and then you have to plan for the treatment, right? So already the bone itself is diseased. Whenever you see a fracture in a diseased bone, that is called as your pathological fracture. And similarly, whenever you see fracture in the normal bone, so fracture, normal bone, but it is normal, right? Then why are we discussing about the fracture in the normal bone? But this fracture is with trivial trauma. So what do you mean by trivial trauma? So trivial trauma is repeated stresses. So a small amount of force. The force is not so high that it results in fracture, but because of the repetitive force, if there is a fracture, then this is called as a stress fracture. So this is called as a stress fracture. So you have two things. So one, you have the pathological fracture. So in fractures, usually how fracture happens, there is a failure in the load of the bone. So actually whenever we are walking or whenever we are doing some activity with our upper limbs and lower limbs, there is some amount of force which is present on the bone. So there is some amount of force which is put on the bone, and if this force exceeds, so high velocity forces are present, then it will result in fractures. But these two fractures are with low velocity forces. So even though there are low velocity forces, but there is a fracture, right? So hence these are special fractures with low velocity force. One is the pathological fracture, the second one is a stress fracture. So pathological fracture in a diseased bone, stress fracture in the normal bone. So this is the difference which you have to remember. And this stress fracture is given a special name which is called as the March fracture. This is called as the March fracture. So usually which is seen in the second metatarsal, that is the neck of the second metatarsal. You see there is some fracture usually seen in soldiers who are marching, hence called the March fracture. And this low velocity force when you seen in the already deceased bone, this is called as a pathological fracture. Then coming to two important complication of the fracture. So two important complications of the fracture. So as I told you, the fracture happens whenever there is a high velocity load onto the bone. So what happens is whenever there is a break in the bone, so that is called the fracture because of high force, or it could be because of the low force as we have discussed before. And this fracture heals, right? So there is a body mechanism which is there which heals these fractures naturally. Sometimes there is a problem to this healing. So sometimes there is a problem to this healing, and this healing problem can be seen in two ways. That is, one is your non-union, the second one is malunion. So when the fracture heals, we call this as union. So when there is a problem, we call as there is no union or there is some problem in the union. So there are two important terms. When there is no union, it is called as non-union. When there is some problem in the union, it is called as a malunion, right? So non-union is absolutely no union, that is no healing. Malunion is there is union but there is some problem. So what is that problem in malunion? That is alignment problem. So there is no alignment. So that is about non-union and malunion. So whenever you see such x-rays, so there is some gap in the fracture. So there is no fusion of the fracture. This is called as non-union. So this is called as non-union. And when you see there is a union but there is no alignment, this is called as malunion. This is called as malunion. So these two are very important. One is non-union, the second one is malunion, right? And then going to the next one. So this is very, very important. Shoulder dislocation. So we are going to shoulder dislocations. So there are three types of shoulder dislocations which you have to remember. The first one is your anterior shoulder dislocation. Then we have your posterior shoulder dislocation. Then we have your inferior shoulder dislocation, right? So the anterior shoulder dislocation, this is the most common type of shoulder dislocation. right? And then in the shoulder dislocation, the most important thing which you have to remember is there is a damage to the axillary nerve. So the one important thing which they ask is there is damage to the axillary nerve. And what is the attitude of the limb? The limb comes in abduction and external rotation, right? So there is abduction and external rotation. So what are the various tests which you have to remember? There is Dugas test. So Dugas test, Hamilton Ruler's test and Callaway's test, right? Hamilton Ruler and the Callaway. So Callaway. So these are the three important things which you have to remember. So Dugas, Hamilton Ruler and Callaway. These are the three important tests which are done to rule out shoulder dislocation. So this is the X-ray of shoulder dislocation, and you see that this is subcoracoid level. So this is the subcoracoid level. Similarly, you will have infraclavicular level also and subglenoid level. So there are three important terminologies: the subglenoid, the subcoracoid and the infraclavicular. Right? So the subglenoid level is most common. Right? So these are the important things which you have to remember. And then coming to the posterior dislocation, what you will remember, the posterior dislocation is the sign which is seen on the X-ray, which is the light bulb sign. So light bulb sign is one which is seen on the X-ray. So that is the light bulb sign where you can see the entire humerus this way. So this is the light bulb sign which we see usually in the posterior dislocation. And what happens in the posterior dislocation is adduction. So there is an adduction and there is an internal rotation. This is the mechanism of injury, and it is usually seen in epileptics. So it is not very common, but usually seen in epileptics or patient who has suffered from shock. So very good. This is the electric bulb sign or the light bulb sign. So in case of epileptics, in case of shocks, if the patient presents with you or the question is framed in that way. So a patient with the shock or a patient shock is that current shock, electric shock. So this is electric shock with electric bulb sign. So that is your posterior dislocation. And coming to the inferior dislocation, inferior is also called luxatio erecta, where this is very, very peculiar, where you see hyperabduction. So what is hyperabduction? So complete high like this. So this is hyperabduction. Even the X-ray is seen that way. So this is the hyperabduction position. So whenever it is abduction and external rotation, this is your anterior, and adduction internal rotation is your posterior, and hyperabduction is your inferior dislocation, right? So that is about the three important dislocation. Remember, the most common one is anterior, and the nerve which is damaged is your axillary nerve. Then what are the complications of the recurrent shoulder dislocations or habitual shoulder dislocations? So there are two important complications which you have to remember. One is called the Bankard's. The second one is called the Hill-Sachs. So what is Bankard's? Bankard's is about the labrum. Hill-Sachs is about the humeral head. If you remember this as H for H. You see this is H Hill-Sachs for the humeral head. Bankard's is the labrum. So what is actually the labrum? Labrum is nothing but the soft tissue which is seen here. So this is the soft tissue. You can see. So this is a soft tissue or the extra part which, if this is the glenoid, okay, now this, imagine this as the glenoid. This is some extra tissue which is seen around the glenoid. This is called the labrum. This is nothing but cartilaginous tissue. This is the labrum which increases the depth of the glenoid so that the humeral head goes and sits inside it. So whenever you see this labral tear, so this labrum tear, whenever you see in the anterior and the inferior area, so this is called as your Bankard's lesion. So anterior inferior area, whenever you see, this is called Bankard's, and humeral head, this is posterior-lateral area. So posterior and the lateral. So just imagine this is the glenoid and this is the femoral head, and this, the pencil what you're seeing, the apple one, that is the anterior part. So whenever the head is going outside it, so outside it there is an anterior part, and the inferior part, the labrum is getting damaged. Similarly, whenever the labrum is getting damaged, for the humerus it is the posterior and the lateral area. So that is how you have to remember. So the Bankard's is labrum and the Hill-Sachs is the humeral head. So the exact, this is the posterior lateral area, that is Hill-Sachs, and this is Bankard's, which is the labrum. And the treatment of this is you treat it with arthroscopic repairs. So now there is a rise of the sports medicine, so that is arthroscopy. You treat this Bankard's and the Hill-Sachs lesion. So that is about the dislocations, right? And now coming to the fracture. So very, very important fracture again. So this is the supracondylar fracture. So here what happens is, in case of supracondylar, if you see just above the condyles, so this is the supracondylar area. So this supracondyle area is nothing but a growth plate, right? So there is a growth plate you see here. So this is nothing but, again, you have to put this under Salter-Harris classification, right? So you put this under Salter-Harris classification, right? So this is supracondylar because it is just above the condyles, and it is of two types. There is flexion type, there is extension type, and this is given by a Gartland classification. So this is Gartland's classification. And what is the most common types? The most common type is your extension type. So extension type is most common. So displacement is mainly based upon your distal fragment. So whenever there is a condyle, that is supracondylar fracture, the distal fragment goes into extension commonly. So the extension type is most common. But what is important for us here? The important for us here, the nerve damage. How do you remember? This is by this mnemonic. So the first nerve is anterior interosseous nerve, and the second nerve is the median nerve, the third is radial, and the fourth is ulnar nerve. So this is how the damage occurs, their nerves. So this is the order which you have to remember. If the examiner asks you, and the supracondylar fracture, the most common nerve to be damaged, you have to tell that is the anterior interosseous nerve. But that is not there in the exam. Then you have to tell it as median. If that option is not there, then radial. If that is not there, then you have to answer it as ulnar. But usually for the ulnar, they give you the side. So if it is a medial dislocation, then you will have this ulnar damage, right? So that is about your Salter-Harris. So this comes under type 1. So this is type 1 of Salter-Harris, that is your supracondylar fracture. And there is one important complication of this supracondylar fracture. This is called as cubitus varus cubitus varus, and this is nothing but the deformity. So this is your cubitus varus deformity, and this is also called your gun stock deformity. So this is your gun stock deformity, or the cubitus varus deformity, right? And then what is cubitus valgus? So we have in the elbow there is a carrying angle, right? In the elbow there is a carrying angle, and based upon that increase or decrease in angle, we call this as varus and valgus. So in case of supracondylar, we read this as varus, but where is valgus seen? Valgus is usually seen in lateral condylar fracture. So whenever there is a lateral condylar fracture, there is a valgus which is seen. So cubitus valgus is seen in your lateral condyle fracture. And this lateral condyle fracture, there is one more important complication which you have to remember, that is your tardy ulnar nerve palsy. So there is a tardy ulnar nerve palsy which you see there in case of your lateral condylar fracture. So tardy ulnar nerve palsy in case of cubitus valgus, and in case of your lateral condylar fracture. But in case of supracondylar fracture, it's cubitus varus, the gun stock deformity. The most common is your AMRU, and one more important complication which you have to remember is your brachial artery damage can occur, and this might result in VIC, that is workman's ischemic contracture. And there is one more important complication, your compartment syndrome. So your compartment syndrome is also seen in case of your supracondylar. So compartment syndrome, VIC, nerve, vessel damage, these are all the complications of your supracondylar fracture, right? But tardy ulnar nerve palsy is seen in case of your lateral condylar fracture, right? And now we coming to fracture dislocation of the forearm. So there are two important things which you have to remember. So one is Monteggia and the second one is Galeazzi. Now identify which one is Monteggia, which one is Galeazzi. So this is Monteggia and this is Galeazzi. So how did I name them as Monteggia and Galeazzi? So whenever I say Monteggia, that means there is a fracture of ulna plus proximal radio-ulnar joint. So what is proximal radio-ulnar joint? It is nothing but your radial head dislocation. So this is radial head dislocation. So if you see, there is a ulnar fracture and then there is a dislocation of the radius. So this is your Monteggia. Now coming to Galeazzi. So what is Galeazzi? Galeazzi, you remember it as fracture radius. And then there is DRUJ, that is distal radio-ulnar joint dislocation. But why are we specifically learning about these two fracture dislocations? Because these fracture dislocations are the fractures of necessity. That means they have to be treated immediately without further delay. So how do you remember? Remember Murg, that is chicken, right? So medial or Montigia is ulna, radius is Galeazzi. And how do you remember proximal and distal? Murg, Punjabi, Daba, right? P is proximal. So Montigia ulnar fracture with proximal PRUJ, that is radial head, and this is radius Galeazzi with distal, right? So Murg is available in the Punjabi Daba. So we remember as Montigia with ulnar fracture, proximal radial ulnar dislocation, and with the Galeazzi radius fracture with distal radius ulnar joint dislocation, right? So these are very important. You have to remember the Montigia and the Galeazzi, right? And next, moving on to the next important one is your Colles fracture. So this is your Colles fracture. So Colles fracture, some important points you have to remember. This is extra-articular fracture. So this is an extra-articular fracture of distal radius. So why am I specifically mentioning about distal radius extra-articular fracture? And a very peculiar feature of the Colles fracture, it is mainly seen in the postmenopausal woman, and it can be an indicator of osteoporotic fractures. So whenever you see a female who is in a postmenopausal age coming with distal radius fracture, these are also with trivial trauma, then you have to evaluate for the osteoporosis also. So whenever you see this type of fracture and there is a dorsal displacement. So what do you mean by dorsal displacement? Again, the fracture fragments get displaced based upon the muscle pull. So in case of Colles fracture, so this is the dorsal aspect, this is the volar aspect, right? So the distal fragment gets pushed over this side. So whenever the distal fragment is getting pushed on the dorsal aspect, which you see on the X-ray, that is called as Colles fracture. So how do you treat it? You treat it with the Colles cast. So what is this cast which I am showing here? This is your Colles cast, right? So what is Colles cast? Whenever you put this cast in palmar flexion plus ulnar deviation. So this is, you have to remember, palmar flexion with the ulnar deviation. So this is how we apply the cast, and what you have to remember is the thumb is free. So why I am telling the thumb is free is there is one more important cast which you have to remember. This is the scaphoid cast. So in case of scaphoid cast, what happens is we enclose the thumb completely. So the thumb is also involved in the cast, but in case of Colles cast, the thumb is lead free. So that is how you have to remember. So there is a palmar flexion. So you're bringing the fragment downward towards the volar, and then you're putting it in its place by ulnar deviation. So palmar flexion plus ulnar deviation, putting the thumb free, is called the Colles cast. If this is not done properly, it results in malunion. I told no, malunion is not uniting. It is uniting in different alignment, right? So this is called the dinner fork deformity. This is called the dinner fork deformity, which is seen in case of your Colles fracture. Then what is this? Opposite of dinner fork. This is called the garden spade deformity. So this is called the garden spade deformity, which is seen in case of your which fracture? Which is seen in case of your Smith fracture. And here what happens is there is a volar displacement of the fragment. So this you have to remember, the dorsal displacement in case of Colles, and for Smith is volar displacement. And what is the deformity? It is the garden spade deformity, right? And there are certain important fractures again. So here we are completing the wrist joint. Now coming to the carpal bones. The most important carpal bone is your scaphoid. So scaphoid, what happens is, the most peculiar thing of scaphoid fracture is there is always a chance of misdiagnosis of the scaphoid fracture. So for that, what they have done is you have to increase the views of identifying your scaphoid fracture. Instead of only taking the PA view, you have to go for the oblique view. So this oblique view will help you in identifying the scaphoid fracture. And clinically, what you take the help of the anatomical snuff box. So here you have the anatomical snuff box, where you take the help of this anatomical snuff box and they pressing over that anatomical snuff box. So this is the area. So this is the anatomical snuff box where you elicit the tenderness. So you will press over that, and if the patient is telling that there is a pain over that particular area, now you order the scaphoid oblique view, and in that you can see that there will be a fracture here. So that is a scaphoid fracture. So there is peculiarity of the scaphoid. So what is that? The blood supply. So the blood supply is peculiar for the scaphoid, where the supply is from distal to proximal. So distal to proximal. And now what are the whenever there is some peculiarity, what are you worried about? You're worried about the loss of blood supply. So whenever you're worried about loss of blood supply, there is one more interesting feature of this. So this might land up in what is called as avascular necrosis, that is called as AVN. So this is investigation of identification. So investigation of choice for identification of AVN is MRI. So on the MRI, you will see that the bone is black in color, it is darker. So this is nothing but the avascular necrosis, where they have neglected the fracture of the scaphoid, and this landed up in complication of the fracture, which is nothing but your avascular necrosis, right? And what is the cast which we are putting? We have already discussed, that is the scaphoid cast, and the position is the glass holding position. So you see this scaphoid cast is putting in one position, that is glass holding position, right? So this is the glass holding position where you see the entire thumb is also enclosed in the cast. So this is the glass holding position for the scaphoid fracture. And then very important for the hand, we have three important fractures. So first one is the Bennett's fracture, the second one is Rolando, and the third one is Boxer's. So let us see what is each. So Bennett's, when I say Bennett's, it is bi. So it is a two-part fracture. So two-part fracture. Rolando is three-part fracture, right? So these two are seen in case of your first metacarpal, that is thumb, right? So first metacarpal is nothing but your thumb. So there are two important fractures. One is Bennett's fracture, second one is Rolando fracture. If you see Bennett's here, there is only one line. So this is dividing into two parts. Where you see Rolando, this is three parts. So it is in shape of Y like this, right? So it is shape of T like this. So Y or T, this is Rolando. Bennett's bi. Bi is for two. So two parts fracture. Why am I so interested in learning whether it's bi or tri? Does the treatment gets affected? Yes, the treatment gets affected because of the attachment of the muscles. So if you see, there is one important muscle which is called as your abductor pollicis longus. So this abductor pollicis longus, what does it do? It is attached to this long fragment here. So this is the long fragment, right? Not to the shorter one, the longer one. So this pulls the fragment downwards, helping in what? It doesn't help. It causing interference with the union. So the union doesn't occur because of that pull of the muscle. So hence you have to properly reduce it and fix it. Reduction and fixation is important for Bennett's. Whereas Rolando, because it is a comminuted fracture, we say this as comminuted fracture because more than two parts it is comminuted. So hence it is a comminuted fracture. You don't aim for a absolute reduction. But Bennett's is a vertical fracture. You aim for absolute reduction because shear forces are high in that particular fracture. So that muscle pull which you have to remember is your abductor pollicis longus. So two important fractures, Bennett's fracture and Rolando. So two important fractures which you have to remember. Then what is Boxer's fracture? Boxer's fracture is fifth metacarpal neck. So this is fifth metacarpal neck fracture is your Boxer's fracture. Then what is this important lesion here? So here you see a small amount of piece here, right? So this piece is nothing but your ulnar collateral ligament. UCL is your ulnar collateral ligament, and damage to this is called your gamekeeper's thumb. This is called your gamekeeper's thumb. So because of the hyperabduction of the thumb, so thumb is going entirely like this, hyperabducted thumb will result in damage of your ulnar collateral ligament. This is called as gamekeeper's thumb. And similarly, if you see this adductor pollicis, so this is nothing but at the base of the phalanx, right? This is the area. So this is the area I'm talking about, the ulnar collateral ligament. So if you see, there is one important muscle here, that is the adductor pollicis muscle. So adductor pollicis muscle. So whenever there is a lesion at the base of the thumb like this, on the ulnar aspect, base of the thumb, so this is nothing but your base of the proximal phalanx. So here what happens, this adductor pollicis, whenever it is coming in way for the union, it will result what is called as the Steiner's lesion. This is called as Steiner's lesion. So gamekeeper's thumb, hyperabduction injury, and whenever this adductor pollicis coming in between this UCL to repair, this is called as Steiner's lesion, right? So these are the different varieties of hands which you have to remember for the exam, right? And now coming to the lower limb, this is the pelvic compression band, pelvic compression belt, and this was asked in the exam. So here what happens is, whenever you see a injury, the pelvic injury, So what is the first step you do? You stabilize the pelvis. So how do you stabilize the pelvis? You use the pelvic binder. So you put the pelvic binder around the level of the greater trochanter. So you use the bed sheet if the binder is not available, or you can use the binder. So somehow you have to close the pelvis ring. If you remember, the pelvis is a ring-like structure, right? So there are two iliac bones with sacrum posteriorly and your pubis symphysis anteriorly. There is a ring. So you have to close this ring. So in case of pelvic fractures, there is an opening of this ring. So this closing of the ring is by your binder. So this is the pelvic binder. So what is the first step you do in case of a pelvic fracture? The first step is you have to first check the vitals of the patient, because there is a high chances of this patient landing up in shock. And then the second one is you put the pelvic with pelvic binder. That this vitals is nothing but you will stabilize the patient first and then you put the pelvic binder. So these are the two important steps which you do. This was recently asked in the exam. And now next, coming to the important questions. This is the what is this? So this is about your hip joint. So in the hip joint we have certain things, certain dislocations and fractures. So this is the posterior dislocation of the hip. And what you have to remember is this is the most common dislocation of the hip joint, that is posterior, and the nerve which is at risk is your sciatic nerve, and the attitude is farther flexion, adduction and internal rotation. So this much if you remember, this is enough. So flexion, adduction, internal rotation. So this is the attitude which they present with, and this is the X-ray, where you see that this is in again the adduction position, and internal rotation as the lesser trochanter is not seen, right? So the nerve which is damaged is your sciatic nerve. And what is this? These are two important fractures. One is your intracapsular fracture and the second one is your intertrochanteric fracture. Intertrochanteric fracture. So intracapsular fracture is called IC fracture and intertrochanteric is IT fracture, where you see shortening in both, right? So there is a shortening of limb in both, but the complications is different. In intracapsular fracture, this is non-union, where the union doesn't occur, whereas IT fracture, this is malunion. So this is very, very important. You have to remember. So this union does not occur and there is high chances of this head going into AVN. Hence, we treat it with hemiarthroplasty. So the treatment is hemiarthroplasty. But for the malunion, what treatment for the IT fracture, you treat it with the proximal femoral nail. So this is what you have to remember, because the fracture is at trochanter region, so there is no problem to the blood supply of the head. So hence we go for nailing, that is proximal femoral nail, which is used for IT, and for the head which we go for hemiarthroplasty, because there is a head at risk. So head, you have to replace the head, which is nothing but your hemiarthroplasty, right? So these are the two important IC fracture and IT fracture, and for this you have to always see that whether the head is dislocated, or if it is not dislocated, then you go for seeing whether there is a fracture, that is it could be an intracapsular fracture or the intertrochanteric fracture, right? Then coming to the femur fracture. So femur fracture, very, very important, is you're dealing with one important complication, the fat embolism syndrome. So there is a fat embolism syndrome which is always at risk with the patients of femur fracture. Usually there will be male fracture, the males, that is young males, and usually there is a delay of 24 to 72 hours after that, which they produce with the petechiae, that is petechial rashes. They present with the respiratory symptom, that is breathlessness, and then present with the neurological symptoms. So neurological symptoms or confusion, they present with they present with neurological symptoms like they get confused or they become aggressive, and breathlessness, shortness of breath, and they produce with petechial rashes or the conjunctival hemorrhages. And all this put together, when you see in a fracture patient, that is especially the femur fracture, because the fat globules get escaped and produce vasculitis. So that is your fat embolism syndrome. So whenever you see patients with femur fracture, you have to evaluate them 24 to 48 hours later for fat embolism. And what is the treatment? This is the internal fixation of the bone with the femur fracture. What you use your intramedullary interlocking nails, but this is for the adults over the age of 20 years, maybe from 12 to anywhere up to more than 18 years, you use the interlocking nail. So this, you see, this is the nail and you have the screws. So hence it is called intramedullary because it is inside the medulla and it is locked above and below by the screws. It is called the interlocking nails. But similarly, if the femur fracture is seen in very early age, like maybe less than 2 years, more than 2 years, or 2 to 4 years, or more than 4 years. So there are different types of treatments which you give. The first one is called the gallows traction. So gallows or the Bryan's traction, it is nothing but the bucks. So you use a skin traction kit, right? And then you put for both the limbs and you elevate the buttocks over the couch. So this is called the gallows traction or the Bryan's traction for the children less than 2 years. If they're around 2 to 4 years, you do what is called as hip spica. You produce this hip spica. So their complete stabilization of the limb with the help of this abdomen. So this is called the hip spica for 2 to 4 years, and more than 4 years, these are called the tense nail. These are titanium elastic nailing system called the tense nail. They are made up of titanium and they grow along with the bone, hence the name elastic. So titanium elastic nailing system, tense nail. There are 2 tense nails which are put, and this gives stabilization to the fracture to heal where the child's age is more than 4 years. So these are the various treatments for the femur fracture. And now coming to the very important fracture, that is the patella fracture. So this was recently asked in the exam where they have shown the x-ray of this. So this students were pretty not sure whether this is we are dealing with the biparietal patella or whether we are dealing with the fracture patella, because the treatment differs, right? So whenever you want to say this as biparietal patella, you see that there is no crack. So this crack is not there in between 2 fragments. So you can see that there is a clear demarcation, and it is usually in the superolateral area. And what you do is you take x-ray of the opposite limb, because in 50% it is bilateral. So for the confirmation, you take the x-ray of the opposite one. So this is the area what I was talking about. The superolateral area is involved in case of your biparietal patella. Whereas in your patella fracture, so this is the areas where it is involved in the patella's fracture, and here what you treat is with the cast. So it could be conservative by the cylindrical cast. So this is called a cylindrical cast, where you leave this up to the malleolus, from the thigh to the malleolus. So that is a cylindrical cast, or you go with the tension band wiring. So TBW is used. That is the tension band wiring which we use for patella fracture. So this is about your patella fractures, right? And then there's a usually injury, direct injury over to the knee joint, which will present with patella fractures. Now coming to few important tests which you have to remember. So the first one is about the ligaments, right? So we have 2 important ligaments, ACL, PCL, and 2 meniscus, medial meniscus, lateral meniscus, and 2 collaterals, that is medial collateral ligament and lateral collateral ligament, right? So the first one is your, yes, the ACL, the anterior collateral ligament, where you draw where you pull the tibia forward. So usually what is the action of ACL? Action of ACL is to resist the forward coming of the tibia. So the tibia can't come forward, the femur, because of the ACL which is resisting it for the forward protrusion. But whenever there is a loss of ACL, you go for this forward drawing, that is anterior drawer's test. And similarly for PCL, we have posterior drawer's test, right? And now whenever you see an image with rotation, so whenever you see the image with rotation, this is for your meniscus. So this is the meniscus. There are various tests which are described for meniscus. So the first one is called the McMurray's test. So what is McMurray's? Where you rotate it. So first you flex it, then do external rotation, right? On external rotation, you do flexion and extension. So if you have pain, it is about your medial meniscus. And similarly, you do internal rotation, and then you do flexion extension with valgus stress. So this is for your lateral meniscus. So meniscus you can do with the McMurray's test, or this is called the Thessaly test. So Thessaly test is for standing. You stand on one leg and you give some 20 degrees flexion of the leg which you are examining, and then you rotate it. So you are trying to rotate the femur over the tibia and testing whether this meniscus is damaged or not. So whenever the person is standing, that is Thessaly test, that dancing movements, and whenever the patient is supine with the rotation, this is McMurray's test. And now when you see the patient in a prone position, so this is a prone position, and now they are doing rotating movement, this is called as Apley's grinding test. So this is called as Apley's grinding test. So 3 important, that is meniscus, McMurray's, Thessaly, and Apley's grinding test. So how do you remember? Thessaly for dancing movements, Apley's grinding is prone position, and then McMurray's is for rotation in supine position. And now you give for valgus or varus stress. So whenever you do this valgus or varus stress test, it is to opening the joints on the medial and the lateral side. So you do opening on medial and the lateral. So you hold the leg, flex it properly to at least 30 degrees, and then you open the joint. So medial side you're opening, that means you're giving a valgus force. So lateral side you're opening, that means you're giving a varus test. So this is nothing but for your MCL and LCL, right? So you're testing the collaterals. So collaterals are tested by your stress test. That it could be a varus stress test or a valgus stress test. So this you have to fill this table. So anterior drawers is for ACL, posterior drawers is for PCL. Again, Latchman's and pivot shift is for ACL. So I'll tell you when is Latchman's used. Latchman's is a very sensitive test. For ACL to test anterior drawers, it should be 90 degrees of flexion. But for Latchman, it is 15 to 30 degrees is enough. And pivot shift is usually done under anesthesia, and it is the most specific test, right? That is what you have to remember regarding your pivot shift test. Then comes McMurray's. We know this is for meniscus. So both the meniscus you can test, and then varus or valgus. So valgus is for MCL test and varus is for LCL. That is both the collaterals. And again, McMurray's is for Apley's grinding test is for meniscus. And then you have your dial test. So dial test is very important, and this is for your posterior-lateral complex. So you have certain complex on the posterior and lateral aspect, which includes your PCL, and there is one more important thing, that is your popliteus tendon, and there are certain elements which are present in that important posterolateral complex, your lateral collateral ligament and your posterior cruciate ligament with some fabulofibular ligaments. There are certain components which are present in it, and this forms your posterolateral complex, and for that you need this dial test. So this, just remember, the posterolateral complex is for your dial test. Rest all is sorted, right? Latchman's is very sensitive, that is for your ACL, but specific is PCL, this pivot shift, right? So this is this two things which you have to remember, right? So these are the various tests which are used for the your ligaments and your meniscus. Now coming to the upper limb, similarly we have rotator cuff, right? In upper limb we have rotator cuff, where we have supraspinatus, and then we have infraspinatus, then we have subscapularis, and then we have teres minor. If you remember, the subscapularis is for your internal rotation, and supraspinatus is for your abduction, and the other one, the teres minor and your infraspinatus, is for external rotation. This much if you remember, it is sorted. So external rotation is by your teres minor and inferior infraspinatus. So you are testing for external rotation, that means you are testing these two muscles. But how do you test for supraspinatus? That is the question. So testing is by empty can test. So this empty can test is for supraspinatus. So you first put empty can. So this is the thumbs up sign. Do it inverted empty can, and then you lift it up. So that is your empty can test for your supraspinatus. So whenever there is supraspinatus tear, you do this empty can test. Then you have your lift off test. So again, it is for internal rotation of the subscapularis. Then you have belly press test, again for your subscapularis. So subscapularis we have two. One is lift up and one is the belly press. So that is your subscapularis. Then for teres minor and infraspinatus, you have external rotation test. So these are the various tests which you have to remember, right? And then coming to the tests which are seen in the lower limb. So the first one is the Trendelenburg sign or test. So how do you do this Trendelenburg? So it is mainly testing your abductor. So what are your abductors? Very important. Gluteus medius and gluteus minimus. So we know that the balance of the pelvis, even if you're standing in one limb, one stance face, if you're standing only on one particular limb, the pelvis is still stable. It is not tilting this side or that side. If you're stable like that, that means your abductors are working. But if there is a dip is opposite. So dip is always on the opposite. That means it is Trendelenburg positive. Understood? Just remember, the dip is in opposite. The sway is on same side. Right? Dip opposite, sway same side. That means the lurch. You're swaying on the same side, but the dip, if you observe on the hip, the dip is in opposite side of the hip. So that is your Trendelenburg's test. Then what is this test? This is nothing but your Thomas test. So this is your Thomas test. So what is Thomas test? So here this is for identifying the flexion deformity of the hip. So what you do is you ask the patient to lie supine, and then you try to flex the opposite limb. So you try to flex the opposite limb completely, so that the whatever the deformity is there, it is identified. So this deformity, that is the flexion deformity which is present in the hip, is identified by your Thomas test, right? And then what is this? This is straight leg raising test. So straight leg raising test is of two types. One is active, the second one is passive. The active test is for your hip joint to note, and passive is identifying your prolapse intervertebral disc, right? So usually it is up to 60 degrees. So if it is less than 60 degrees, if the patient is having pain along the sciatic nerve, this is your straight leg raising test. So because sciatic nerve is present entirely on the posterior side, and now as you're lifting this leg, this nerve gets stretched, so you will have pain, right? So whenever the angle is less, that is below 40, 420, that means it is severe sciatic nerve compression. If it is above 60, there is a pain, there is no inference for disc prolapse, right? So that is how you have to remember, this is a straight leg raising test, right? So a passive is nothing but the clinician raises the limb. Active is the patient itself raises to test the hip joints, whether the hip joints are connected. Like in case of fractures, the patient will be unable to do this active SLRT. So when I say Thomas, there is one more test which is called as Thompson test. So what is this Thompson test? This is for your integrity to test the tendo-Achilles. So what is tendo-Achilles? When the gastrocnemius and soleus come together, they form the tendo-Achilles, right? And whenever you press or you compress the gastrocnemius, the calf muscles, you will see there is a plantar flexion, right? So tendo-Achilles is for plantar flexion. So absence of this plantar flexion, that means there is a tendon rupture. So the test for tendo-Achilles is Thompson. The test for flexion deformity is Thomas test, and there is a Thomas collar. There is a soft collar which I have shown you in the first slide, that is your Thomas collar. So this is the Thomas test, the Thompson's test, and the Thomas collar, right? So these are the various tests. Now what is this? Identify the structure on the MRI. So this is the MRI, and what is this? And similarly we have this. So what is this is, you already have identified that this is a knee joint. So you know this is the patella, this is the femur, and this is the tibia. Now what you have to identify is, this is the anterior aspect of the tibia, this is the posterior aspect of the tibia. So some structure is coming and attaching on the anterior aspect. So this is probably ACL. And similarly, if you see, this is again patella, femur, and tibia. So patella is on the anterior aspect. So this is something attached to the posterior. So PCL. So cruciates are named according to their attachments to the tibia. If they are attached anteriorly, this is ACL, and if they are attached posteriorly, that is PCL. And what is ACL tear and PCL tear? The absence of this particular structure on the MRI. If you don't see this particular structure on the MRI, that means it is called as ACL tear. If you don't see this particular structure on the MRI, then it is called a PCL tear, right? So this is ACL and this is PCL. Understood? Very good. Now coming to the ankle fractures, we see that there is some fracture here. So when you see bimalleolar fracture, so the two malleoli are fractured, this is called as Pott's fracture. Pott fracture. When it is trimalleolar, so what is the third malleolus? You know median malleolus, you know lateral malleolus. There is one more malleolus on the posterior aspect which is called as the posterior malleoli, which is only seen in the lateral view. So that is why you have to get AP view, lateral view, and one more special view which is called as mortise view, right? So mortise view is to identify the joint properly. So this is one of the important question. So the special view for your ankle is, it is the mortise view. And whenever there is a trimalleolar fracture, so there are three malleoli which are damaged, trimalleolar fracture, that is your Cotton's fracture. So Cotton's fracture is trimalleolar, bimalleolar is your Pott's fracture, right? And what is the classification which is used? It is called the Long-Hansen's classification, which is asked in the exam. So this is the Long-Hansen's classification, where it is divided based upon the position of the foot and the force applied. So position of the foot, supination or pronation, and the force applied, whether it is external rotation or adduction. So that is how the classification is mainly described. So Long-Hansen's classification. And now let us see a few important angles which are asked in the exam. So orthopedic angles. The first one I know you all can read. This is the carrying angle. So what is a carrying angle? The carrying angle is one which is mainly long axis of the arm with the long axis of the forearm. That's it. Long axis of the arm, long axis of the forearm. It is carrying angle, more seen in females. It is more in case of females, right? So that is carrying angle. Whenever this angle is lost or increased, this is called as, usually it is valgus, right? So whenever there is lost, it is varus, or it is coming towards inside, that is varus, and if it is increased, it is valgus, right? So this is nothing but the carrying angle, long axis of the arm with forearm. And what is this? Alpha and beta, where you see this is seen in case of DDH, and where you see in case of ultrasound, and this is used for identifying the DDH, whether it is the severity of the DDH. So what happens here? The alpha angle decreases, the beta angle increases, right? So the alpha angle decreases, the beta angle increases. So that is your alpha angle, alpha and beta angles which are seen on ultrasound in case of DDH. Then what is this? This is Bowman's angle. Bowman's angle is seen in case of your elbow. So in elbow, what you have, this humeral. So this is your humeral and this is your capitulum. So humerocapitular angle, mainly you have to compare it with the opposite side, and it should not be more than 5 degrees of deviation. If more than 5 degrees of deviation, then there is some abnormality. So it may result in varus or valgus, right? So this is the capitular angle, usually seen for fixations in supracondylar fractures mainly, right? And then what is this? This is 𝐒𝐿H's angle. So 𝐒𝐿H's angle is seen in CTEV, so congenital talipoequinovarus, and you see usually this angle is at usually these lines, the talus and the calcaneum. So this is talus and this is calcaneum. Usually they are present at an angle somewhere around 25 degrees. So if it is coming to zeros, here you can see what is called as parallelism. So parallelism of the talus and the calcaneum, this is called the 𝐒𝐿H's angle, which is seen in CTEV. And next one, this is called the Bowler's angle. So Bowler's and the Gissen's. So Bowler's and Gissen's is seen in case of calcaneum fractures. So calcaneum fractures, especially the intra-articular fractures, if you see, there are two important angles, the Bowler's and the Gissen. So Gissen, there will be increase. So Gissen is for gain. So there is an increase, gain in the angle. Bowler, low. So there is a decrease in the angle. So increase in the angle, decrease in the angle, which comments upon the calcaneum fractures, right? So you have to remember Bowler's and Gissen's are seen in case of calcaneum. Then finally you have Q angle. So Q angle is nothing but your quadriceps angle, usually in case of patellar dislocations. These are seen in case of patellar dislocations. They play an important role in patellar dislocation. So these are various angles. So one is the carrying angle. As we know, normally it is cubitus valgus, right? Whenever this is decreasing, it goes into varus. So varus and valgus is by carrying angle. Alpha beta for DDH, usually seen on ultrasound. Then Bowman's angle in case of your elbow fractures, and 𝐒𝐿H's angle in case of CTEV, where you see parallelism. In CTEV you see parallelism. Normal it is some angle which is making, but when you see 0 degree or parallelism is CTEV, right? And then in calcaneum you have Bowler's and you have Gissen's. So Gissen's is gain of the angle, that means angle increases. In Bowler's, angle decreases. So whenever the angle is decreasing, that means there is a calcaneum fracture, right? And Q angle is used, that is quadriceps angle is used in the case of your patellar dislocation. Then what is this? This is your bumper's fracture. So this is your bumper's fracture. That is your lateral condylar fracture. So bumper's fracture or the lateral condylar fracture, right? So simple isolated lateral condylar fracture is bumper's fracture, but sometimes this lateral condylar will be associated with the meniscal tear. So what do you see on the meniscal tears? So depending upon the zone. So this is also recently asked question. So outer to inner. So from outer to inner we have 3 zones, right? So this is the red zone. You can see the red color, then you can see some lesser red, that is red and white zone, and finally is the white zone. So what do you think will be the answer? So meniscal, whenever there is a tear in the red zone, you can go for repair of the meniscus. When you go for red white, you can take a chance, but in white zone you take meniscectomy. That means you remove, right? So you go for removal of the meniscus. That means there is no healing which is seen in case of your white zone. Understood? So red zone, whenever there is a tear, that means you can still repair the meniscus. You can give time for it to heal. So this is exactly what I'm trying to tell. So this is the red area where you repair the meniscus. That means you don't remove the meniscus. Here you remove the meniscus because there is no chance of healing. So complete meniscectomy. Here you can give a trial of either repair or remove based upon your experience or based upon this zone. If it is near to this, you remove. If it is near to this, you repair. Like that. It is a gray area. So this is the important question which was asked again in the exam, the zones of the meniscus. Next, coming finally to the fracture of the talus, which is again very important. It is similarly like your scaphoid, where there is a peculiar blood supply to it, and hence there are chances of it going into AVN. So talus fracture is called the aviator's fracture. So it is called the aviator's fracture, and if not treated properly might result in AVN, and this is the sclerosis. That means it is resulting in AVN. But what is Hawkins sign? What is Hawkins sign? Hawkins sign is one sign where there is a lucency which you can see. What do you mean by lucency? Lucency is nothing but there is the, that means the talus is still alive, right? So talus is still alive. So talus is not gone into AVN. It is not dead. That is Hawkins sign positive. So when you see lucency, that is Hawkins sign positive. When you see sclerosis, it is going into AVN, right? So that is going into dead, that is dead bone, that is sclerosis. Next, coming to the this fifth metatarsal base fracture. So this is nothing but your Jones fracture. Jones fracture is nothing but your fifth metatarsal base, that is your Jones fracture, very important. And this Jones fracture is again, you have three areas in this where you, depending upon that, you treat it. So for now, just remember that there is a fifth metatarsal base fracture. But when you see an avulsion of just the base, it is called as pseudo Jones. Pseudo Jones. Just an avulsion fracture is your pseudo Jones. So Jones fracture and pseudo Jones fracture, that you have to remember. Then coming to the pediatric fractures. So here we have a buckling. So just you can see the buckling of the cortex, right? So this is called the buckling of the cortex. So this is nothing but your torus fracture. And here you see there is a break in one cortex. This is your green stick fracture. So green stick fracture. So whenever there is a break in the cortex, usually pediatric bone are made up of water. So when you try to break it, there is only break in one cortex and the other cortex is intact. This is called as green stick fracture. This is called as a buckle. So you don't see any break. There is just a rounding thing like this, right? So there is a rounding of the cortex. So that is your torus fracture, right? And then you see this fracture. There is a small fracture line in the tibia, which is usually seen of less than 3 years age, right? So this is called as toddler's fracture. Toddler's fracture is again a simple fracture which is seen in tibia, usually missed sometimes. So this is the toddler's fracture in the tibia. And now what is this? Just for completion's sake, this is a night stick fracture but not a pediatric fracture. Don't get confused between green stick and night stick. Night stick is isolated fracture of the ulna. Lati fracture. So just as a defense mechanism, if you put your hand over your face to protect it, and then the stick comes and gives a good blow or good force onto the ulna, so there will be an isolated fracture of the ulna. So that is called your night stick fracture. Fine. And now coming to the, this is the Salters-Harris classification where the growth plate. So first one is a normal fracture. There is a normal physis, and whenever the fracture is straight without any disruption, that is through and through the physis, this is called the S, that is type 1. And whenever it is going through the metaphyseal region, so that is above the physis, this is A, that is Salter type 2, right? And this is L, T, and ER. That is what I want to tell. That is Salter-Harris classification. So how to remember? This is to the zone of hypertrophy. That is what you have to remember. The first type 1 is zone of hypertrophy. So this is type 1. Then type 2 is above the epiphysis. So it includes something like the metaphysis, right? And L is 3. So it is going lower to below it. So this is including the what? Including the epiphysis, right? And then T. When you say T, it is through it. So this is 4. So 4 is through, that is it includes the meta and the epi. So both. So physis, the above and the below. And ER is the crush injury, right? So just for the completion's sake, so the type 1 is through the physis. Through the physis is a straight through the physis zone of hypertrophy. A is for above the physis, so it includes the metaphysis, right? And L is lower, that it includes the epiphyseal region. And T is through, that is metaphysis and epi. And then ER is a crush injury, that is Salter-Harris type 5. This is 5. Right, so that is how you have to remember. Very important Salter-Harris classification for your exam, right? So I have told you the example of SCIFI type 1, that is Salter-Harris, is first one is supracondylar fracture and SCIFI, both are type 1. And lateral condylar, you can take the supracondylar, again you can take it as type 2 if there is a fragment which is there, metaphyseal, or type 1 depending upon the fracture pattern. But the lateral condyle is type 3. The lateral condyle is type 3. The lateral condyle is type 3, that is including the epiphysis, right? So that is about the Salter-Harris. And now coming to the CTEV, pediatric. So this is what? So this is CTEV, congenital talipes equinovarus, or this is also called as club foot. How do you treat it? You treat it with the casing. So you do serial casing. So serial casing is done by which method? You use the Ponseti technique, and this Ponseti technique in terms of CAVE. So first you correct the cavus, then you correct the adduction, then varus, then equinus. So that is the correction, and this is called as Dennis-Brown splint. So this is called as the Dennis-Brown splint. So this is the Dennis-Brown splint, and now this is the CTEV shoes. So this is the CTEV shoes which we use for the this is the CTEV shoes which we use for the treatment. This is the maintenance treatment. So this is the maintenance treatment for your for the condition. So first, whenever you see a patient with CTV, you go with serial casting. You start as immediately as possible. That is, you do serial casting every week. That use the technique which is called as Ponseti technique. And then we use what is called as these shoes for maintenance until the child starts walking. So this is called the Dennis-Brown splint. And then we conclude it with the CTEV for maintaining the correction, right? And then what are these two things? So this is for the DDH. So DDH is, you have two screening tests for DDH. So one is your Otterloni and the second one is your Barlow. So Barlow and Otterloni are the two screening tests for DDH. So what you do is, in Barlow you will bring the hips outside. So this is the Barlow is you do adduction and internal rotation, and in Otterloni you do abduction and external rotation. So that is what you have to remember. And then here you have important lines to remember, that is H line and P line. So H line and P line is Hilgenrinus line, which is a straight horizontal line. So this is a straight horizontal line, and then we have the Perkins line. So this is the Perkins line, which is the vertical line. And here what happens is, in case of DDH, you see this X-ray. So this X-ray you see in the upper outer quadrant, right? So whenever you see that the head is not present in the inferior quadrant but in the upper quadrant, that means it is DDH. So how do you treat it? You treat it with the Pavlik harness. You treat it with Pavlik harness, right? So this is the thing which they have asked in the exam. So this is the image based question for DDH. This is the Pavlik harness. Then what is this? So this is nothing but your Perthes. So there is an avascular necrosis. So this is your Perthes disease. So avascular necrosis of the femoral head. So avascular necrosis of the femoral head is nothing but your Perthes disease, right? So the Perthes disease, you see the head has to be spherical like this. So this is the head. Now there is loss of the sphericity of the head, and this head, this is nothing but the Perthes disease, where you see in 4 to 8 years of age. 4 to 8 years of age, that is the Perthes disease where we see, right? And then we are going to one more important condition, that is skiffy. As I've told you, this is nothing but there is a slip capital femoral epiphysis, and what you have to remember is only one thing, there is a Trethoven's sign. So this is the Trethoven's sign where you see, so this is the slip I was talking about. So this is the slip. If you see, the epiphysis is like this, but here you see there is a some slip of the epiphysis, right? So epiphysis is dislocated, and this is called the skiffy. And where you see this is usually seen in a male patients which are obese patients. So these are male patients, obese patients with endocrinopathies. So these are endocrinopathies like you see with hypogonadism, right? So you see patients, they are present with hypogonadism, or they present with various endocrine abnormalities like the diabetes. So whenever you see a patient with diabetes, hypogonadism, and obese patient and male patient, and they come with pain in the usually they come with pain in the knee joint, because from the hip joint the pain gets radiated to the knee joint. So usually this skiffy condition we usually neglect it, because they complain pain in the knee, and when we do check in the knee there is no abnormality, right? So then you have to think that this is a radiating pain from the hip, and you have to get an hip x-ray, and this special x-ray what you have to order is frog leg view. So frog leg lateral view. So this is the x-ray which we order, and that particular x-ray what you see is this particular slip you see here, this here. So this is the particular slip. So this is the skiffy, slipped capital femoral epiphysis. So these are the three conditions you have to learn in the pediatrics. One is CTV, the second one is DDH, and then your skiffy, right? And one more not to forget is your Perthes disease, right? And then what is this? So you will see there is elevation of the scapula. This is called the Springel's shoulder. This is called the Springel's shoulder, where you see there is an elevation of the scapula. Elevation of the scapula, right? So this is also recently asked. And then there is one more thing which is called the Klippel-Feil syndrome. So there is a triad. This is usually because of there is a the cervical vertebra get fused. So the patient complains of flexion limitation of the cervical spine. So whenever you see a spine which is, there is some complaints in the cervical spine associated with short webbed neck. So there is a webbed neck and there is a low hairline, and on the x-ray you see there is a fusion of the vertebra. So here if you see this line, there is not there, right? So there is these two vertebrae are fused. So this fusion of the cervical vertebra on the x-ray along with the low hairline and short neck is nothing but your Klippel-Feil syndrome. That is the segmentation of the vertebrae is a problem. So that is the thing. Segmentation of the vertebrae is the problem. So these are all the image based questions. So the Springel's shoulder, where you see the elevation of the scapula and you see the short neck with the low hairline, and on the x-ray you see there is a failure of the segmentation, that is Klippel-Feil syndrome, right? So these are certain conditions which you have to remember. And now coming to the compression thing, like these are certain nerve compression syndromes which are again asked in the exam. So first and most important is your carpal tunnel syndrome, where there is a compression of the median nerve. So how this is happening? So carpal tunnel is the area here. So here this is the area where you have all the flexors which pass from your forearm into the hand, right? So while passing there is a tunnel which is present here. So this tunnel is called your carpal tunnel, and whenever there is the volume of this tunnel is decreased, or there is some abnormality in the tunnel which is causing decrease in the space of that particular area, and this causes compression over one particular nerve which is called as the median nerve. So this is carpal tunnel syndrome. Then there is a compression of the median nerve, right? And there are certain tests which you have to remember for this. So first is the carpal tunnel compression test, or the Durkin's test. So Durkin's test or the carpal compression test. And then you have Fallon's sign. So Fallon's sign is you do like this, reverse. So your actually causing the flexion of the this area, right? So flexion of this area, which again will cause decrease in the volume of that particular space, and they will produce symptoms. Or sometimes even the reverse phalanx test or the tunnel sign, all this put together, they give you a diagnosis of the carpal tunnel syndrome. And what are these important words which you have to remember? Usually the pain is nighttime, right? Nighttime, and when there is a hanging of the hand over the bed, right? That means there is hanging of the head over the bed. That means it is going into flexion like this. So this flexion of this wrist, that means that whenever there is a flexion, there is a compression of the nerve which produces tingling and numbness over the lateral one, 3.5, that is your thumb and the index finger. So these fingers are at risk. So I've told you the median nerve is all about your thumb and the index finger. So again, median nerve, there will be tingling sensations and loss of or decreased sensations over the thumb and the index finger. So that is your carpal tunnel syndrome, right? So compression of the median nerve. Then what is Guyon's canal? Guyon's canal is your ulnar nerve. Guyon's canal is ulnar nerve. And what is piriformis? Piriformis syndrome is sciatic nerve. If you remember, there is a greater sciatic notch and lesser sciatic notch. So there are sciatic nerve which enters to greater sciatic nerve, passes through the piriformis muscle. So this piriformis muscle, whenever there is within the substance of the piriformis muscle, so this gets, the sciatic nerve gets compressed over here. So then it produces symptoms, that is pain, tingling, numbness along the limb. So that is the piriformis syndrome. Then pronator is again median nerve, where the median nerve travels through two heads of the pronator teres. So that is your pronator syndrome. Then cubital tunnel is again ulnar nerve. Cubital tunnel, if you imagine the cubital tunnel, it is the ulnar nerve which is present. So that. Then tarsal tunnel is posterior tibial nerve. Then meralgia paresthetica and chiralgia. Meralgia is lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh, and chiralgia is the superficial radial nerve. So superficial radial nerve. And motor metatarsalgia is the interdigital nerve. So this is the interdigital nerve, right? Mainly the second and the third toe. So these are certain nerves or compressive, or you have to remember. So mainly remember that Guyon's canal, you know, that is a pisiform. There is ulnar nerve, piriform is sciatic, pronator, median nerve, and so on, right? So just take a screenshot and remember. Now coming to the infections. So just quickly I'll go through the infections. So this is the, so if you see, there is one sclerotic bone inside it, surrounded by lucency, right? Surrounded by lucency. So this is nothing but your sic vestrum, and the lucency is the involucrum. So this is nothing but your chronic osteomyelitis, right? So this is the chronic osteomyelitis. And then you see there is a periosteal reaction. This is Gary's sclerosing osteomyelitis. So sclerosing matlab there is lot of periosteal reaction. So this is Gary's sclerosing osteomyelitis. This is an area where the defense mechanism of the body is high. Hence it is able to control the infection. But there is only the periosteal reaction which is present, right? So this is just a Gary's and the Brody's abscess. So Brody's abscess is again the same, where you see there is a lucency just high, nicely situated in the tibia. So the margins are very well defined, everything is very nice, because the body is able to confine the infection to that particular area. This is the Brody's abscess. So these two are low infection, right? And body defense is high, right? Whereas chronic osteomyelitis, the high virulent organism and body defense is low. Body defense is low. So that is how this is converting into chronic osteomyelitis. Here these are just X-ray findings, the Brody's abscess and your Gary's sclerosing osteomyelitis. And then what is this sign? This is the Canavel sign. So what is a Canavel sign? So this is about the tenosynovitis. Tenosynovitis, especially the flexor tenosynovitis of the fingers, where there are 4 things which you have to see. First, there will be fusiform swelling. So fusiform swelling because the entire sheath is present over this thumb, right? So there is an entire sheath which is present like this. So this is the sheath. So there's fusiform swelling of the entire finger. Then what you see is the flexion. The fingers are in flexion, right? And on extension, they will have pain. So pain on extension. So these are the terminology which we have to use for canaval stenosynovitis. So you will see the entire fusiform swelling with the fingers in flexion position, and whenever you try to extend them, they will wince with the pain, right? So this is the flexor tenosynovitis. Then these are called the canaval's sign. So canaval's sign, right? So that is about the infection of the tenosynovitis. Then coming to the infection of the spine, the most important one is the TB spine. So what are the most important things you have to remember? Mostly seen in the dorsal spine, right? And the most common presentation is paradiscal type. So paradiscal type, most common. And how do you treat it? So the middle path regime is what is usually taken for the treatment. And what is the brace which you use? The Taylor's brace. So the whatever the pus which is present, it can travel and can present as psoas abscess or the bird nest abscess. So that is what you have to remember. So bird nest abscess or the psoas abscess. So this is regarding your TB spine, right? So there is some amount of this curve, this is called the knuckle, the gibbous or the kyphosis. So if it is 1, it is knuckle. If it is 2 vertebrae, it is gibbous, and if it is more, it is kyphosis. So these are terms which you have to remember. And when you're coming to the TB, the spine is the most common one which is affected. Next is your hip joint. In hip joint, you have to remember there are 4 stages, and in the last stage, you remember what is called as 2 radiological features. One is called the wandering acetabulum. So that means the cup is enlarged, and there is a femur head is become small, and it keeps moving inside the acetabulum. So if this is the cup, this is the femur, and head, this is, keeps moving. That is called the wandering acetabuli. And the one more thing what you have to remember is the motor and the pestle appearance. So motor and the pestle appearance, right? So these two are seen in case of hip joint. So first thing what you have to remember, the spine, TB spine is most common, and then in the joints it is the hip joint which is the most common. And what is spina ventosa? This is also recently asked. What is spina ventosa? It is digits. So whenever there is a TB of the digits, it is called spina ventosa. What is caries sicca? Caries sicca, sicca is shoulder, TB shoulder. So caries is dry, right? So that is TB shoulder is caries sicca. So what you have to remember is wandering acetabuli and motor and pestle appearance of the acetabulum, and femoral head is seen in case of TB hip. And now coming to very, very important, rickets and scurvy. This is also asked. So what is basic pathology in rickets and scurvy? Rickets may, what you'll have is there is no mineralization. That means no mineralization means no calcium, right? When there is no calcium, everything appears dark, right? But when it comes to scurvy, it is, what is the defect is? Defect in the collagen. That means defect in the cartilage, but good mineralization is there. So whenever you see good mineralization, that means everything is white in color. So if you see the x-ray, right, so everything is dark, like fraying, spraying, cupping. So there is absence of physis properly, so the cup is deformed. So there is a cup like depression over here. So this is like depression, so this is called the cupping. And there is a fraying, so there is small amount of deposition like this, and splaying, so it is spread over it, right? And when I come to scurvy, you see everything is in white, right? So you can see one white line of Frankel first of all, and there is a ring sign. So ring sign is, so the epiphysis is surrounded by one line of sclerosis, and then there is a Pelkan spur. So but one lucency is scorbutic zone. This is the lucency what you see. So you have just remember that if there is more of white, remember this as scurvy. If it is more of dark, it is your rickets. But this terminologies is important. So in scurvy, what is important is the Pelkan spur. This is nothing but the lateral area is the Pelkan spur. The ring epiphysis is Wimberger sign. So Wimberger sign, there is a ring epiphysis. And then you have this white line of Frankel. So this is white line of Frankel, where there is a provisional, so there is a dense calcification which is called as white line, and the scorbutic zone is the lucency. The lucency is the scorbutic zone or Trumperfeld zones. So these are the important things. And in case of rickets, we remember there is a cupping, spraying and flaying, and these are certain important things and association with the rickets you can see, right? And now coming to, so this is the X-ray which has been presented. So you can see there are certain areas. So these are called the Lucer's zone. So when you see Lucer's zone, And this is what? This is called the protrusio acetabuli. That means the acetabulum, the femoral head is going inside, right? You can see there is a protrusio acetabuli. So normally it is like this, but there has been movement towards the medial aspect. So this is called protrusio acetabuli and the lucid zone. This is commonly a feature of osteomalacia. So similarly, whenever there is a mineralization problem, so mineralization problem in the adults, the bones become weak, right? So no mineralization in adults, the bones become weak, and this is called as Yash Patel. See, I want to tell many things, but now little time constraint. But dependent and independent, how to differentiate is you have to take the biochemistry analysis. So whenever you take this biochemistry analysis, and you will see that there are certain levels which you have to identify for vitamin D, and then you will give. Then if you think there are some abnormality in the biochemistry, then you have to treat it accordingly, whether it is vitamin D dependent or vitamin D independent, right? So I will put it as a text after the class, how to differentiate in detail, okay? So now in this osteomalacia, you have looser zone. So whenever there is a defective mineralization, as Yash has told, there is a vitamin D deficiency, right? So vitamin D deficiency, whenever there is a vitamin deficiency, there is no mineralization, right? So hence they will develop rickets. And similarly, if there is a vitamin D deficiency in case of adults, there is osteomalacia. That is, you will find this looser zones, pathological fractures, and this protrusio acetabuli. And what is this? What is this? This is resorption of the bone, right? So there is resorption of the bone, especially on the radial aspect. So whenever you see this particular resorption of the bone, this is nothing but your hyperparathyroidism. So you take hyperparathyroidism, that is, there is an increase of parathormone hormone, right? So this parathormone hormone, you already know that it is in love with calcium. So there is an increase in the calcium, decrease in the phosphorus, right? So whenever there is an increase in the calcium, that means it wants more and more calcium. So whenever there is increase in PTH, it wants more and more calcium. So to get that more and more calcium, what it does is it causes resorption of the bone. So this resorption of the bone, especially seen in the phalanges. So especially seen in the phalanges is nothing but your hyperparathyroidism on the X-ray. And now as the resorption occurs in the bone, this forms a cyst here. So as the bone, this forms a cyst filled with fluid or the blood. This is called osteitis, that is bone fibrosa, that is fibrous tissue cystica. So this can be a confuser again for the tumor. So this is nothing but hyperparathyroidism. The bone gets resorbed and it is filled with the fluid or blood resembling as a cystic lesion in the bone. But this is a osteitis fibrous cystica. It is also called as Brown's tumor. It is also because of the blood. It is also because of the blood, the color is brown color. Hence it is called the brown tumor, usually seen in hyperparathyroidism. Right? So these are certain important X's which you have to remember in case of your Paget's disease. So this is the Paget's disease. So what happens in Paget's disease? Paget's disease is nothing but seen in elderly above 60, where some abnormality in the remodeling. So we have two phases. One is the blastic phase and the second one is the lytic phase. So these phases will present this as the picture frame vertebra. So this is the picture frame vertebra or the ivory vertebra. So the picture frame vertebra or the ivory vertebra is seen in case of your Paget's disease, and this is your rugged Jersey spine. So rugged Jersey spine is again seen in case of your Paget's, right? Rugged Jersey spine where there is a striations, like these are the various striations. So white, lucency and white. So this is the as if appearing as a rugged Jersey spine, right? So this is seen in case of various other osteopetrosis also. You can see this rugged Jersey spine, and you can see this is in Paget's disease also, right? Hyperparathyroidism also, hyperparathyroidism and your Paget's disease can produce this rugged Jersey spine and Paget's, right? And then what is this? So this is easy. This is codfish vertebra. This codfish vertebra is seen in case of your, yes, osteoporosis. So this is seen in case of your osteoporosis, where there is a DEXA scan to analyze the bone, and this DEXA scan, the T-score should be more than 2.5. So this is the DEXA scan, that is codfish vertebra is seen in case of your osteoporosis. This is bullet shape. This is seen in case of achondroplasia. So this is seen in case of achondroplasia. So that is about the various x-rays. And what is this? This is osteogenesis imperfecta. Osteogenesis imperfecta, where you see that there is a damage to collagen. So especially the type 1 collagen, there are two types, that is CoL-A1, CoL-A2. These two genes are important to remember, and there is blue sclera which is present, and there is dentigenous imperfecta, that is involvement of the teeth. So that is about the osteogenesis imperfecta, where you see the bones get deformed and you see there are multiple fractures. So right, there are multiple fractures which you see, but there is no problem in healing. So hence you can see that the bones get healed, but there are multiple fractures, and various stages of fracture healing can be appreciated. So various stages of fracture healing can be seen. So this is osteogenesis imperfecta, because of deficiency of type 1 collagen. So very, very important again in exam point of view. And what are these? These are certain soft tissues. This is called the Dupuytren's contracture, and this is usually seen because of some abnormality in the myofibroblast. So myofibroblast abnormality will cause the contracture of the middle finger. So contracture of the ring finger, usually ring and the little finger. So contraction of the ring and the little finger. So this is called the Dupuytren's contracture. This is again nothing but the fascia which is present that gets contracted, right? And this is similar to your Lederhouse and the Peyronie's disease. So Peyronie's is again for the penile fascia, right? So penile fascia, and Lederhouse is for your plantar fascia. So this is again the contracture of that similar variety. So Lederhouse disease and Peyronie's disease for penile fascia. So this is Dupuytren's contracture, where you see there is a contracture of the ring finger, and you can see there is a thickening of the cord, and because there is an abnormality in the myofibroblast and the palmar fascia, right? So that is the Dupuytren's. And what is this? This is your trigger finger. This is your trigger finger. Trigger finger is where there is a damage to your sheath. So there is a A1 pulley which is getting damaged, and whenever the tendon is moving inside the sheath, it produces snapping sound, because there is a nodule or some thickening of the sheath which is not allowing the tendon to move freely, and hence with the movement you will hear the snapping sound. So this is called the trigger finger, and what you have to remember is A1 pulley is involved in it. And what is this? This is Prayer's sign, asked recently in the exam. So Prayer's sign is nothing but an indication of the diabetic keratorthropathy. So it is also called as Charcot's joint, where they become stiff. So this is called the stiff hand, where the patient is unable to do prayer. So he is unable to put his hands like this, hence you can see the hands going wide apart. This is called diabetic keratorthropathy, usually seen in diabetes. Then these are certain fractures of the cervix. So Jefferson's fracture. So F is present, that is the first, that is atlas bone is fractured, bilateral, you can see. Then this is Hangman's fracture, where there is a traumatic spondylolisthesis of C2 over C3. This is Hangman's fracture. And this is Clay-Chauverlet's fracture. This is C7 fracture, that is your spinous process. Spinous process is fracture. This is very simple fracture, that is Clay-Chauverlet's, but this is listhesis, spondylolisthesis. Spondylolisthesis, this is your Hangman's fracture. Jefferson's, F for first. Remember, this is an ring-like structure, right? So this is a ring-like structure, and bilateral fractures you can observe, right? So that is your Jefferson's, Hangman's, and Clay-Chauverlet's. And if you see, this is PIVD at L5S1 level. It is causing the obstruction to the flow. That nerve is getting compressed. This is called prolapse intervertebral disc disease. And now this is, if you see, there is a protrusion of forward vertebra. This is called as spondylolisthesis. So this is called as spondylolisthesis, right? So you have to see the alignment of the vertebrae. One vertebra is front of other. So forward protrusion of the upper vertebra. This is called spondylolisthesis. And what is this sign? This is called as the shopping cart sign. So shopping cart sign is seen in lumbar canal stenosis. So this is asked in the INICT. So shopping cart sign is seen in the lumbar canal stenosis, where flexion position or stooping forward will decrease the symptoms because the canal is increased. On extension, the canal becomes narrow, hence causing the symptoms of lumbar canal stenosis, such as your neurogenic claudications. And finally, we are up with the few, this is called the Sach foot. This is called the Jaipur foot. Sach foot, you see everything is wood, and this is metallic heel, where you see there are three parts to it, right? So this is entirely as one part. So this is entirely as one part, where you see this is ankle part, heel part, and forefoot part. Hence, this is good. I mean, like your Jaipur foot is good, where you can do dorsiflexion, plantar flexion, inversion and eversion, right? So movements are possible. You cannot use the barefoot walking, is not possible. So barefoot walking you cannot do. This you can do barefoot walking. So you can do barefoot walking, and you can walk on the uneven surfaces. So all this, if you see, this is used for the Indian scenario, hence the name Jaipur foot, which was developed in Jaipur itself. So this is the you can walk on uneven surfaces, you can do plantar flexion, dorsiflexion, you can walk on uneven surfaces. This you can't walk barefoot, you can't walk on the uneven surfaces. This is your Sach foot, right? That is it, and these are just the names. This is the periosteum elevator, and this is your osteotome identification, and this is your bone clamp, right? And two types of fixators, external and internal. This is your X-fix, which is of two types, rods and tubes. So this is your rods, and this is your ring external fixator. Ring external fixator is called the Ilizarov. And this is your rods. I told you there are rods, right, and pins. So this is your X-fix. So you see, this is used for open injuries. And what is the classification of open injuries? This is Gustello-Anderson's classification which we use. And whenever you see an open injury, you go with either X-fix, right? So either you go for rods and pins X-fix with two straight rods is present, right? And then you go for ring external fixator, which is called as Ilizarov. And finally, internal fixation. This is your DCP, dynamic compression plate. So this is used for the compression, the fixation of the fractures. If this is the fracture, so now after putting this plate, this fracture gets compressed because of the fixation techniques. Hence, it is called as dynamic compression plate, right? So similarly, you have locking compression plate, where you have threads. You have this. So if this is your screw, you see that there are threads in it. So whenever you see threads over it, it is locking compression. Whenever you don't see threads, just an oval surface, so this is locking. Whenever you see like threads, something like this over the plate, right? So this is locking compression plate, but no threads here. So this is dynamic compression plate. That is how you will identify. And finally, thank you so much for your patient listening. I have extended the time very, very significantly. So I just wanted to cover everything, because just to get to that 100% recall rate. So let me know after the exam how many questions were answered after this watching your video. Fine. Thank you so much. See you again. Bye.